Good afternoon. So we'll be talking about today the waveform part of OSCE exam, that is pertinent to the DRNB or DM critical care exam. This has been fragmented into different sections, and there are various faculties are taking different parts of it. And I am assigned to the ventilator graphics, arterial waveform, a CVP waveform and ICP waveform. Rest of that in the list will be covered by someone else. So let's about ventilator waveforms first. This is a very frequent question in the exam. You will get at least a section of the OSCE on this. And there are not many abnormalities that is asked in the exam, ventilator waveforms. There are very few of them, and if you master them you should be able to easily identify and answer it. So they are really solid marks fetching questions in the exam. So try to concentrate on the various waveform and look at few of the examples or pictures to have your understanding clear about it. Now, ventilator asynchrony or patient ventilator asynchrony is a phenomena that occurs when patient are unable to breathe comfortably when they are connected to a mechanical ventilator, and it becomes particularly challenging as patient is unable to verbalize his discomfort. That can lead to further patient distress, increasing sedation, length of stay, and also other complications that can happen with the asynchrony. Um, this is a chart which looks at various types of asynchrony that can happen. We primarily divide the whole gamut of asynchrony that is there in when the patient is on a ventilator that can happen is into two major categories. One is called as the phase asynchrony, and the other one is a flow asynchrony. So basically, phase asynchrony means how the cycling and trigger and trigger varies, or how the cycling and trigger settings can influence the patient's comfort or discomfort and his or her breathing um, with the ventilator. So they are primarily divided into two types. One is a trigger or asynchrony related to abnormalities in trigger, and asynchrony related to abnormalities in the cycling. I hope you knows this. You know these phrases such as trigger cycle or flow cycling, etc. So we'll talk about that in subsequent slide. So trigger or issues of trigger can be fourfold. There are four different types of problems with trigger that can happen. One is called as a reverse triggering. The other one is called as double triggering, then ineffective triggering, and auto triggering. Mind you, bit difficult to delineate these abnormalities in a patient when he's having it in the ventilator screen. But I'll try to explain some physiological concept behind it, why it is called as reverse, why it is called as double, why it is called as auto triggering and ineffective triggering. So that's the majority of the asynchrony that you can see during the ventilator patient asynchrony, or this is major chunk of abnormality that you see. But still you can have some cycling abnormality, premature cycling and late cycling. Again, one can be coexisting with multiple abnormalities. So it's very hard to delineate what is happening at the same patient at one moment. And the third is flow asynchrony, which is again insufficient flow or excessive flow. So majority of the abnormality happens in the field of trigger. There's some abnormalities that can happen with cycling and flow. We'll start with the trigger. Now, trigger, as I said, there are four types of abnormality that we see. One is called as the reverse triggering. Reverse triggering is basically the name is self-explanatory. It is reverse. So what happens is usually the patient effort triggers the ventilator. In this case, the ventilator will trigger the patient. So that's the bottom line of it. So what happens is the ventilator gives a breath. This is the volume time curve. The ventilator gives a breath. With that breath, the chest gets expanded and the diaphragm gets stimulated. This leads to contraction of the diaphragm and continuation of the inspiration further. So this is called as reverse triggering. Instead of patient triggering the ventilator is triggering the patient or triggering the diaphragm to contract. Then this is followed by a normal ventilator breath, and again the ventilator breath triggers the patient. The diaphragm contracts and there is a breath taken or given, and then the usual expiration. So that part of the volume time curve is abnormal. This is because of activity of the diaphragm in response to the air or whatever is going into the lung by the ventilator, triggering the diaphragmatic contraction. Uh, so the reverse triggering corresponds to the respiratory muscle effort, as I said, triggered by the reflex mechanism. So this is a reflex mechanism, nothing to do with the ventilator, nothing to do with something problematic. This is the reflex contraction of the diaphragm from the insufflation of air into the lungs by a ventilated control cycle. The tidal volume, so what happens, the consequences of that is you have set a tidal volume of 450 or 445 there, but because of this reverse triggering, the patient is delivered some higher amount of tidal volume up to 700 or 800. So there will be excessive volume delivery to the patient, causing the consequences of that. All right. So this is called as reverse triggering. It can happen in assisted control ventilation mode, but can also occur in a pressure support ventilation also. In case of double or reverse triggering, there is a phenomena called as breath stacking. So this is breath stacking. So if it comes in your exam as a spotter, what do you see in this picture? So the buzzword will be double triggering and breath stacking. You have to talk about breath stacking. That's the word the examiner is waiting for. As I said, this can lead to increased delivery of the tidal volume, can cause barotrauma and also volutrauma, which can also lead to ventilator-induced lung injury. The cause is spinal reflexes that governs the supply to the diaphragm getting activated. And also sometimes patient hiccups can cause those things. But again, hiccups is not particularly by the definition of double triggering. It doesn't account for that, but it looks the same, or the pathophysiology of that is also the same, because hiccups leads to contraction of the diaphragm. All right, so that's again a reflex, which may not be induced by air going into the lung. Hiccups can be due to different things. The second problem is auto triggering. Auto means automatically it is triggering the ventilator. So how the ventilator is triggered? Either it is a flow trigger or a pressure trigger. So any abnormality or any changes in the flow or pressure detected by the ventilator will trigger it to give a tidal volume. In this case, as you can see, these are oscillations. Probably there are changes in intrathoracic pressure because of just contraction of the heart that is causing some trigger. Not all of them are triggered, but you can see this volume is triggered or triggering a ventilator induced breath. So this is called as auto triggering, which is not there, not set in for this, but automatically the ventilator gets triggered by this. So the causes can be various. There are various causes to that. I'll go in detail about that. Just again, similar type of picture you can see it is getting auto triggered. Again, these are ineffective triggers of the cardiac activity, but this one becomes effective and there is a breath given. All right. A little bit about auto triggering. So the ventilator triggers a cycle by improperly recognizing a variation of flow or pressure in the circuit as a spontaneous respiratory muscle effort by the patient and tries to support it with the breath. The causes can be various, just not only cardiac oscillation, it can be leaks in the circuit. It can be condensate in the filter or HMA filter that can cause it. Transmission of intrathoracic pressure variation by heartbeat or by the ejection of the systolic volume can also trigger it. Any sort of leak in the circuit, such as a chest drain or a bronchopleural fistula, can cause that. Even large amount of respiratory secretion, like patients with bronchiectasis, can have this. And also simple swallowing or vomiting of the patient can cause auto-triggering. The risk is overventilation or hyperventilation, and the expiratory time becomes shorter because they are triggered very frequently. There will be frequent repeated breaths without adequate expiratory time. So there will be retention of the volume that is given and there will be autopeep generation. How to treat it? So first of all, look what is causing it and try to correct that. If there is a condensate or there is some liquid in the circuit, try to take it out and make sure that the trigger setting is adequate. It is not a low trigger like at 0.8 liters or 0.5 liters. So you increase it to 1-2 liters depending on what the patient requires. All right. Again, a little bit of briefing about double triggering. What happens is there are two types of breathing time. One you set on the ventilator, which is called as the ventilator set time or inspiratory time that you give. But also the patient has a neuronal time which is governing its ventilation. Like if my body requires an inspiratory time of 5 seconds, so that's my neuronal breath time for that patient. But you set a time which is less than or more than the neural time in the ventilator, then there will be issues. Somebody needs a inspiration of 5 seconds, and if you set it for 3 seconds, then his inspiration will be incomplete, leading to air hunger and other consequences of that. Okay. So that's where the double triggering happens. So double triggering is a phenomena where there are two consecutive inspiratory breaths happens, and between each breath, the mean inspiratory time is less than half of the time of the ventilator set time. For example, if you have put an inspiratory time of 1 second, and if you have two breaths coming within less than time of 1 second, like 0.5 second, 0.6 seconds, that means double triggering is happening. Okay. Now, double triggering can be because of many causes, but the bottom line is when the neuronal time for the patient is more than the set time for the ventilator. The patient requires an inspiration of 4 seconds and you have put it at 2 seconds. That means it is going to breathe. The patient is going to breathe in between. That will cause double triggering of the ventilator. Now, causes again, if the patient is febrile, having a high respiratory drive, he will be breathing faster. If you have set a low tidal volume and he requires more, then he will breathe more frequently. Or as I said, you have put a shorter inspiratory time compared to a neuronal time that the patient has a longer inspiratory time requirement. It can lead to again breath stacking and ventilator-induced lung injury. What we can do is changing to a lower expiratory flow trigger like the patient is allowed to breathe for a longer period of time without cycling from inspiration to expiration. I'll tell you with the subsequent figure what I mean. Or you can sedate the patient again, switch to assist control mode, or switch to pressure control mode, which is more control and sedating the patient. Okay. Or the third thing that you can do is to increase the inspiratory time, matching the patient's requirement. So there is always a dilemma. How do you distinguish between a reverse triggering and a double triggering? It's very hard. As you can see in the picture, they look almost similar. It has to be some clinical sense going into this differentiation. We'll go one by one and see how can we distinguish between the two. So we know reverse triggering happens because a patient inspiratory effort that is reflexively triggered by the ventilator derived breath. So ventilator gives a breath and somehow the diaphragm senses that there is some air coming in or some sort of stimulation to the diaphragm, and the diaphragm contracts after that, causing another inspiration. So that's the mechanism how reverse triggering happens. We talked about that. Now double triggering is when the neuronal time for the breathing for the patient is more than the set time. So he needs to breathe more compared to what is he allowed to. Okay. So in that case, 2 consecutive ventilator breaths delivered for patient's inspiratory effort. Now here the things happen from ventilator to the patient. The ventilator causes the patient to sense something and then get another breath. So the what you call the command flow is ventilated to the patient. So machine triggers the patient effort. But in case of double triggering, the patient triggers the ventilator, where the patient demands for more breathing and keeps on breathing. So that leads to frequent breath to the patient. So here the command is from patient going into the ventilator. Sequence of event. So ventilator gives air, insufflate the lung, and there is delayed diaphragmatic contraction. But in case of double triggering, patient inspiratory effort, ventilator gives a breath, then the patient put another effort because it is inadequate, and then triggers a second breath. So it is all patient control or patient induced thing. Usually for a reverse triggering, the patient is very deeply sedated and is passively ventilated because it is a reflex mechanism that is happening. The patient usually does not control it, and usually the patient is very deeply sedated, and in that case the diaphragm is active and it can have some sort of reflex activity. But in double triggering, the patient is fighting. The patient is more awake, lightly sedated, or spontaneously breathing. So patient has more demand, more awake in case of double triggering. Now timing of patient effort, again the same thing, we're going around in circles. So patient effort occurs after the start of the ventilator inspiration. So initially there will be ventilator breath and then there will be diaphragmatic contraction. In this case, patient effort persists beyond the ventilator inspiratory time. Even if the ventilator has gone into expiration, the patient still continues to breathe. Waveform, what are the changes? Unfortunately, they look probably more or less similar. Okay. So in the pressure waveform, you will see that rise in airway pressure late in inspiration or during expiration. Very hard and very subtle to look for, but the pressure rise will be late. The two pressure peaks in rapid succession, you will have two pressure peaks like that. Okay, in case of double triggering. The flow, secondary deflation in flow following the ventilator breath. So in case of double triggering, there will be two inspiratory flow peaks without expiration in between. So the flow will have usually no time for expiration. So you'll be having one flow here and then another flow there. There will be no coming to the baseline and then going up like this. Okay. So it is again very subtle, as you can see both the pictures, but the flow amount in the expiration is very low in case of double triggering. And volume, there will be breaths taking in both, hard to delineate which is causing what. Okay. Further, in reverse triggering, as I said, the neural time and the patient set time or the ventilated time. In reverse triggering, the neural inspiration lags the mechanical inspiration. The neural inspiration is shorter, but the mechanical inspiration still goes on. Other way around, for the double triggering, here the neural inspiration is longer, the demand is longer compared to what the ventilator is providing. Respiratory drive, usually low, reflex mediated, it is a reflex mediated phenomenon, and the patient is usually heavily sedated in this case, but in double triggering, the patient will have air hunger, inadequate support, and will be restless. Airway pressure impact, both will have elevated peak and plateau pressure, and both will have volutroma and barotrauma. Diaphragmatic impact, the reverse triggering can cause eccentric diaphragmatic contraction, can lead to diaphragmatic injury. In case of double triggering, diaphragm generally contracting appropriately but excessively. There will be excessive functioning of the diaphragm. What happens if you increase the sedation? In reverse triggering, may worsen or persist because it is a reflex mechanism. In case of double triggering, it often helps in alleviating the issue. So it can get rid of double triggering if you sedate the patient more. Response to increasing the tidal volume or inspiratory time, what will happen? So it will resolve double triggering, and also it can improve reverse triggering also. Bedside clue, what do you look for? Even if the patient is totally sedated, not moving, still there is an ongoing asynchrony, means it is possibly reverse triggering. If the patient is already tachypneic, air hungry, and there is obvious patient effort going on, it is double triggering. Management, usually in reverse triggering, you reduce the entrainment of air, like adjust the rate, switch the mode, and allow spontaneous breathing in this case. But in double triggering, you match the ventilator support to the patient demand by increasing the flow cycling. Like if it is cycling at 30-40%, reduce it to 15 or 10%, increase the rate, increase the volume. All right, we'll talk about that again later on. Example, any question, any suggestion what's happening in this? Anyone wants to answer?
It's a double triggering, sir, because in the pressure time scalar, after the inspiratory peak, there is again one more upward waveform.
Mm-hmm.
And then in the flow also, there is again like expiration is not complete in the first waveform. The flow time scalar.
Mm-hmm.
After the inspiration, there is no expiration, followed by again there is a pause, and then one more inspiration happens.
Yes. So if you have a double triggering, what you do is, so initially the flow cycling was happening, whatever, take it 40% or 50%, as you can see in this. We have reduced the flow cycling to from 40 to somewhere between 30% or 10%, 20%, reduced it. So that you have more inspiratory time and longer delivery of air, and that gets rid of the double triggering. So one of the measures what you do is to reduce the percentage cycling of flow. So initially it was cycling at 40%, we reduce it to 10%. So decreasing the expiratory flow trigger allows for a longer flow time and thus larger tidal volume be delivered. All right, now premature cycling. So that's about trigger. There are four types of trigger we talked about. I think I have few slides of ineffective triggering at the end. Now cycling issues. So cycling issues can happen before time or after time. Similar to the previous picture that we see here, this is premature cycling happening, or in a way you can say it is premature because the patient has still ongoing air hunger. So this is called as premature cycling. This one. So again, similar premature cycling. So the patient does not get adequate air or time to breathe. So particularly it happens in restrictive lung disease, and where the patient will expire prematurely. Here the dot indicates the timing of cycling in the breath during pressure support ventilation, which is premature because you can see in the expiratory phase also the patient has some effort or generating some effort to breathe further. Similarly, late cycling, you can see the flow waveform comes down and stays like that for a long time before getting into cycle to expiration. So this is allowing a lot of time without cycling to the expiration. The patient needs to expire here, but we have not allowed him to expire till this time. So this is late cycling. Okay, this happens usually in COPD patient where the inspiratory time is short, and if you keep them giving air, the expiratory time becomes shorter and they need more expiration or expiratory time. So is late cycling, which is not acceptable in a COPD patient. So this is a COPD, pressure support ventilation mode. Breath cycling occurs late in relation to the end of patient's expiratory effort. The dot indicates here is late cycling. So you'll have this type of chair pattern in the flow curve. Sometimes what happens is you, as you can see, here the cycling should happen somewhere there, 20%, 25% of the flow there. But it is not happening even there, prolonged to that phase, and the cycling is happening beyond that. So you're allowing extra time, which may cause pressure rise, which is called as late cycling pressure overshoot. If you have a late cycling, because of the accumulation of air, you can have a pressure overshoot in the pressure time scaler like that. Okay, so that's an important finding in case of late cycling. So this is a patient on pressure control ventilation. Pressure overshoot occurs at the end expiration with an elevated elevation of airway pressure during muscle relaxation. Airway pressure rises by effect of an high inspired tidal volume. Because of this late cycling, it is allowing more inspiration to happen. So how do you fix it? So premature cycling, usually the mechanical ventilator inspiratory time is less than the patient neuronal inspiratory time. Again, the same funda of double triggering. Causes, there can be ventilator causes or there can be patient related causes. Ventilator related causes is inspiratory time is too short relative to patient inspiratory time. We have set a shorter time frame, which leads to premature cycling. Patient related causes is restrictive respiratory mechanics in pressure support ventilation, where you have a lung fibrosis and the patient goes into the expiration very quickly because of the lung mechanics, recovering ARDS, high respiratory drive and short time constant. So in those cases you can have a very premature cycling. What can this lead to? So it can lead to dyspnea. Obvious dyspnea, you can see the patient has a high respiratory rate because of repeatedly cycling into expiration, and it can cause patient discomfort. So how do you do, how do you manage? So if the patient is a volume control mode, decrease the inspiratory flow or increase the tidal volume. So if the tidal volume is 120 150 ml with each breath, try to give that tidal volume, make it higher, like double 300 350, looking at the pressure changes, limiting pressure changes. If the patient is on a pressure control mode, increase the inspiratory time. So the same amount of air can be delivered over 2 seconds or 3 seconds instead of 1 second. Okay, so increase the inspiratory time in pressure control mode. If the patient is on a pressure support mode, decrease the cycling threshold percentage. So initial cycling was happening at 40%, reduce it to 10% or something. Patients with COPD develop late cycling and restrictive disease have early cycling. Okay, that's the bottom line to remember this. Bit of late cycling so occurs when the ventilator offers a mechanical inspiratory time longer than the duration of patient muscle effort. So you keep on giving air to the patient even if it doesn't need it. It needs to be recycled into the expiration. Usually more than 150% of the patient's neuronal inspiratory time. Uh, this can cause again respiratory discomfort, dyspnea, hyperinflation. Solution is to decrease ventilatory inspiratory time. What can you see here? Anyone? in the pressure waveform and in the flow waveform? What sort of cycling happening? Anyone wants to answer? What sort of cycling happening here? Or abnormality? So what is this one in the flow cycle? Somebody had told early, that's correct. So what is that represents? That or that? Yep, it's a premature, that's correct. But what sort of, why you say it is premature, that's important. The examiner will be asking that premature cycling, why it is happening. All right. This is patient effort. The patient is still not completely happy with the inspiration, so gives another effort there. Is there any double triggering? No, probably not as yet. Is there any breath stacking? Possibly not, because you can see the breath completes here and it goes down, it's not going up there, so no breath stacking. But this can lead to double triggering or ineffective breathing and breath stacking if it is not answered. So the ventilator's inspiratory time was shorter than the patient respiratory muscle inspiratory time. So the requirement was higher compared to the set time. So this is shown in the expiratory segment of the flow curve, which tends to return to baseline or to become positive as a result of the patient inspiratory effort. So it gets up again. Similar thing. So what we did is initially the cycling was at 25% of peak inspiratory flow. We reduced the cycling to 5% of the peak inspiratory flow, and this was negated then. So you can see there is no patient or minimal. In this one there was none. So better synchrony. Again, premature cycling, you can see. So here we have inspiratory cycling off at 40%. So that's 40%, 40%. That's where, and then it was followed by a breath by the patient, not happy with the cycling. So we increase the cycling or decrease the cycling threshold to 10%, and now it is more synchronous. There is no double triggering. Okay, this one has a double triggering also. Okay, so on the right, the cutoff cycle point was reduced to 5%. This one, prolonging the inspiratory time and improving the synchrony. Similar thing. What's happening here? What have we done? So this is flow cycling happening at 50%, 25%, 10%. If you have premature cycling, you need to reduce it to whatever percentage to gradually reducing values from 50 to 10%. What's happening here? This is the other way around. So the patient is looking at that flow. What does that mean? It's cycled very late, right? He should have been cycling here, but he's cycling here. So which is quite a length of time where there is ongoing breathing, not allowing him to expire. So what would be the consequence of that? Anyone wants to answer that?
The expiratory time will be shortened.
Hmm. No, just the consequence of this. If the patient needs to be cycled here, but we don't allow him to cycle there and allow him to cycle much later on, what are the consequences you can see in this waveform?
Breath is talking, sir.
Breathtaking, yes. And what is that?
Auto peep, sir.
Yes. So you generate a auto peep also because you're not allowing enough expiratory time to the patient that needs. So you can see this was the expiratory time here. When we reduce the cycling from or increase the cycling from 10 to 25% on this one, you get more expiratory time and the flow coming to the baseline. If we further increase to 50%, you don't lose that much of time also. So the patient needs a reduction in his inspiratory time, thereby increasing the expiratory time and allowing to breathe, and there will be no breath stacking and no auto peep. So flow and pressure waveform represents, this is a COPD patient. Asynchrony is corrected by increasing the threshold percentage of peak inspiratory flow for termination of inspiration, increased from 10% to 25 to 50%. All right, next is ineffective triggering. So as the name suggests, it is ineffective. The patient keeps on breathing or sending signal, but the ventilator doesn't recognize it. What else is happening in here? Can you see something there? What is this?
Delayed cycling.
Delayed cycling. So can delayed cycling and ineffective breathing can happen together? What do you mean by delayed cycling? So we have allowed a lot of time for the patient to breathe, to take inspiration, isn't it? He hasn't done it here, he has done here. So what does that mean? Because if he has done it here, then would have been another breath there. It can happen together because there is asynchrony there. When the patient is trying to breathe, he is not allowed to breathe, or the patient is not, or the ventilator is not able to sense it. And when the patient should not be allowed to breathe further, like the inspiration should terminate here, we are allowing more time for the patient to inspire. Um, if there is ineffective triggering, doing that will not help. So you have to reduce the trigger so that the ventilator becomes more sensitive to that rather than giving more time to inspiration. So somebody, if you find a ineffective triggering and if you increase the inspiratory time, it will not help. You have to reduce the trigger. Okay. So this is showing ineffective effort there. Patient with airflow obstruction or difficulty triggering due to presence of auto peep also, even with a physiological muscle effort but unable to trigger the ventilator. So auto peep is a major issue for ineffective triggering because the patient has to overcome that much of auto peep. Suppose you have put a pressure trigger of 2 but the auto peep gen is 6, so the patient has to generate a pressure of 8 or negative pressure of 8 for the ventilator to sense a positive 2 trigger, pressure trigger. So if there is auto trigger, no, if there is auto peep, then it is very difficult for the patient to trigger the ventilator. So that is one of the cause for ineffective triggering. So in that case, you have to look to treat the auto peep to reduce the ineffective triggering. So there are many causes of ineffective triggering. Again, similar, you can see ineffective triggering not followed by breath. So it should be followed by a breath here, but it is not. Similar here, you can see there is dip. The patient is taking a effort, but it is not reaching the trigger which is set at -2 or something. So it is still not reaching. Once the patient becomes more active or more awake, more stronger, then he can generate that negative pressure, and that is followed by a breath. The ventilator can be set in pressure trigger and flow trigger that you guys already know. Usually default in our setting is a flow trigger. Again, this can be seen, there is not adequate flow or negative flow generated. The moment the patient generates that flow, reaches the flow trigger followed by a ventilator breath. Similarly, again, patient effort but no breathe, patient effort, no breathing. So what happens is patient inspiratory effort fails to trigger ventilator, resuming a wasted effort that results to increasing fatigue, tachycardia, increased metabolic needs, fevers, etc., which again can generate so it is worse if there is associated autopeep. It is worse if the patient has a respiratory muscle weakness, and the other issue that can precipitate is inappropriate sensitivity setting. Sometimes the sensitivity may be like we have kept a flow trigger of 5 liters or pressure trigger of 5. So in that case, the patient will not be able to reach that level in any case. All his effort will be wasted. Same here, you can see ineffective triggering. Probably that one is effective, and that's where the breath starts. Causes, what can be the cause? First of all, poor sensitivity trigger that you set. High tidal volume, if you set a high tidal volume, the patient doesn't need to generate more things and will not. High peak inspiratory pressure, um, that can be associated with ineffective triggering, and high level of pressure support also. If the patient is already supported with a high level of pressure, he will not generate much, and the pressure that he generates spontaneously will be less. So these are the predisposing causes for ineffective triggering. What it can cause? Wasted effort, as I said, and there may be changes to the muscle. So even if the respiratory muscle and diaphragm is trying to breathe, it is not allowed to breathe because the ventilator cannot sense it. In that case, can lead to wastage of muscle mass, and muscle training will not happen. How do you change, or how do you correct the situation? You decrease your flow trigger from 2 liters to 1 to 0.5, etc., and then titrate based on the patient awakeness and effort. And if it doesn't, if you don't think that it is required, you don't need to the patient to breathe because the patient has already some sort of lung injury and you want to protect with a protective lung ventilation. In that case, you have to sedate and paralyze the patient. That can take away that abnormality. Insufficient flow, again, it can lead to double triggering. So you have to see this scooping type of thing, and also you can see there is two peaks in the pressure. So flow received by the patient is lower than his or her requirement or ventilator demand. Typically occurs in situation while the inspiratory flow is fixed. That is, it is adjusted by the operator and cannot be increased by spontaneous effort of the patient, as occurs in the volume control mode. So you have a fixed flow here, not like the pressure control where the pressure is ramped or the flow is ramped to a particular pressure. In this case, if the requirement is higher, then insufficient flow will lead to, initially there will be a peak and then followed by another peak in the pressure. Patient is simulated, so the dot represents the maximum drop of airway pressure curve, where because the flow is not adequate, the patient will try to breathe on top of that, leading to a negative pressure and then going up on the pressure here. Insufficient flow, how do you do? So reduce patient ventilator demand, correct hypoxemia, fever, anxiety, pain, etc., so that the patient starts to breathe normally, less frequently. You can increase the flow. When you are setting the patient on a volume control mode, the patient is on volume control mode, you can switch to a pressure control or pressure support mode and have a flow profile more responsive to the patient's demand. It shortens the rise time. So if you shorten the rise time, then the flow can be met easily. Also in modern ventilator, you have adaptive flow mode, which comes as integrated to that. So sometimes you don't have to bother about for this asynchrony, but you have to look at the flow time and pressure time. If the pressure time curves falls and then again have a peak, that means the flow is not adequate. You need to increase the flow. Excessive flow, it can happen sometimes. The patient doesn't need that much of flow, and then you can have issues, this type of waveform in the pressure time curve causing overinflation also. So can lead to pressurization and characterization, a flow inlet overshoot in pressure control or pressure support ventilation. You can see there is overshoot. So how to treat it? Reduce the flow supply and reduction of the pressure value applied above the PEEP. So if you reduce the, suppose pressure control mode, you have kept as an inspiratory pressure of 30 and a PEEP of 10, so total pressure of 40. In that case, you don't need that high pressure, so you may need to reduce it. So there is excessive flow that is generated, you don't need that overshoot, so you may need to reduce the inspiratory pressure in a pressure control mode. Okay. All right. So what's abnormality you can see here on the pressure. So there is a negative pressure generated by the patient and deforms the shape here, which is called as a scalloping, where the patient needs more flow. The patient is asking for flow to be increased. This drop of pressure suggests that the flow rate is too low and you need to increase the flow. So we talked about that. If there is a low flow, you will have a scalloping in the pressure waveform. That is a diagnostic marker of low flow state and you have to increase it. You can see that scalloping also in the flow, like that, flow time scalar. If you increase the flow, then it gets better with a regularized pressure time scalar there. So this is scalloping, that is important finding for flow deficiency. A bit of auto PEEP measurement. How do you do? So you do a expiratory hold, usually 3 to 5 seconds. Allow the alveolar pressure to equilibrate with the airway pressure. So you keep a expiratory hold. There's a button on the ventilator depending on which type of ventilator you are using. You can put it for that length of time and it will read a pressure. Here the auto PEEP is 10 centimeter of water. So auto PEEP accounts for both external PEEP that is given to the patient and the PEEP generated inside called as intrinsic PEEP. So this is other way around. So the total PEEP that the patient experiences is the intrinsic PEEP plus the external PEEP that is given. So if you have a ventilator setting of 5 centimeter of water PEEP, so that's external PEEP, and the intrinsic PEEP is 10, so 10 plus 5 is 15 PEEP the patient is currently on. Again, this is air trapping or dynamic hyperinflation. You can see these type of changes where your volume time scalar will have a progressive upward trends, where because of the retention of the volume it will keep on increasing from the baseline, and also that distance will also increase gradually. So there is a ramping up of the volume time scalar that you get in a auto PEEP situation. Similarly, in the pressure time, you can see the baseline of the pressure gradually goes up. I am not going in detail of the mechanism of auto PEEP, suggesting air trapping. As you can see, it should finish here, but it is not finishing the expiratory flow, and there is auto PEEP generated. So on the flow time, you will have that efficiency that you can see. So causes of auto PEEP, very frequent question in the exam. Inadequate expiratory time, too high respiratory rate, long inspiratory time, prolonged exhalation, and patient with emphysema, etc. can cause it. Also, sometimes the advanced waveforms that you see on a flow volume loop, the volume should come to 0, but it is not. It is ending before this. So this is the retention of air in the lung. Air trapping is happening. So if you look at the flow volume loop, the end expiration will not reach the baseline or 0 point. What is this again? So this is again auto PEEP, where you have generated that much of auto PEEP from the baseline or applied PEEP. By increasing the PEEP, the effort required to generate. So external PEEP, role of external PEEP in auto PEEP, what happens is you can put some external PEEP to splint the airway so that more air can be exhausted through a splinted bronchus rather than a compressed bronchus. So we'll talk about that. Probably there's a picture on this. So how to eliminate auto PEEP? First of all, that we see So changes, you can suction the patient, bronchodilator, anti-inflammatory like steroids, and if there is a kink or something, you correct that. Shortening the inspiratory time and lengthening the expiratory time, that's the usual maneuver you do in a COPD patient. And reducing an above normal minute ventilation. If the patient is getting a lot of flow or lot of volume, you need to reduce it and sedate the patient if required, if the respiratory rate is too high, to give adequate expiratory time. So that's how you eliminate autopeep. We're talking about the external pressure. So suppose consider this is an alveoli which has a pressure inside of 10 centimeter. That's your intrinsic peep or autopeep generated. And in this case, the patient has to generate at least 10 centimeter of water or slightly more than 10 centimeter of water, 11 centimeter of water, to allow some air coming this way into the alveoli. But if we put some extrinsic peep of 8, so that peep and that peep counteract each other, causing splinting of this airway, keeping it bit more open, and the effective peep difference becomes 2, the auto peep becomes 2, and the patient can have some air entry into this and also air going out of it with a lower effort. So we usually sometimes put a extrinsic peep of around 80%, 70% of the intrinsic peep, if to see whether the airway gets splinted, doesn't collapse, and allow some better air entry compared to keeping them at 0 peep or minus peep. So sometimes the extrinsic peep helps, which is called as the waterfall effect. So you put around 80% or 70% of the intrinsic peep externally so that there is patency is maintained and this airway is splinted. That's about the ventilator waveform. So basically you need to practice the ventilator waveform so that you can answer that in a minute time looking at the patterns, and try to classify what type of abnormality the patient has, whether it is a auto or whether it is a trigger issue, whether it is a flow issue or cycling issue. So those phases you have to identify. If it is a trigger issue, what type of trigger issue out of those four, like auto, reverse, a double, etc. So what type of trigger issue it is. If it is a flow issue, what type of flow issue, high flow or low flow. And then there may be coexisting thing, like you saw double triggering along with a low flow state, or flow scavenging or flow scalloping present with a double trigger. So there may be coexisting things there. You have to develop some wording to talk about, so particular buzzword in each of that finding, so like breath stacking, auto peep, flow starvation, scalloping of the scalar. So all those things, particular wording, the usually the examiners are very fond of. So make sure that you practice around 50-60 waveforms, 3-4 types in each a type of abnormality, and what are the things that you need to talk about there. Okay, high probability 50% time you will get a auto peep type of waveform in the exam, very fond of. And the second possibility is ineffective triggering or a double triggering. So these are the 3 or 4 things are very frequently asked in the exam. All right, we'll go to the next stage, arterial waveform. So arterial waveform has 2 limbs. One is called as the anacrotic limb and diacrotic limb. Post the systole, there is diacrotic limb, but not exactly post systole. It is the diacrotic arch. After that, the diastole starts. The diacrotic limb, when the waveform starts to fall, that's where the diacrotic phase starts. I don't have to explain in detail of these things, but the area under this waveform represents your mean arterial pressure. So if the area is higher, the mean arterial pressure will be higher, and vice versa. The waveform can look different at different sites of measurement, and also even with the different numbers, like the same systolic, in this case you can see the systolic pressure is same in both cases, but the map is higher here compared to there because the area under this curve is higher compared to that. That means you have adequate map here you may not have adequate map here because of your low diastolic pressure. The diastolic pressure is higher here compared to this, so the map is higher and the area under this curve is higher. Now, as I said, difference in the waveform. As you go away from the aorta, the diacritic notch starts to fall away. Okay, initially in aorta, it is very synchronous with the systolic peak, then it gradually goes down and further. So as peripheral as the artery, like in dorsalis pedis, the diacritic notch is too low there. Okay, same thing suggesting here. This is the aortic waveform. This is a femoral waveform, and it's a dorsalis pedis waveform. Now there are two abnormalities that is seen in a arterial tracing. One is called as overdamping, the other one is called as underdamping. This is very frequently asked in the exam. This is normal waveform. You can see the overdamping. You guys are probably master in it. And this is underdamping. Now, how to check it? We do usually a fast flush test where we, depending on the resonance frequency of the circuit, the waveform should come to baseline within 2 strokes. If the baseline is not achieved within 2 strokes, that means it is underdamped. Like suppose it needs 4, 5, 6 strokes. That means there is too much of resonance abnormalities in the circuit and the circuit is stiff and you have a lot of vibration going on till it becomes normal. That means it is underdamped. If it comes to baseline with 1 stroke or less than that, then it is overdamped. What causes underdamping and what causes overdamping? So overdamping is caused by air bubble in the tubing, clot in the catheter, any kinks, loose connection, and if the artery is in spasm. So all this can cause a overdamped waveform where you can see the diacritic notch is lost, the height is low, systolic peak height is low, though the map can be same with the normal arterial waveform, but the height is low. This is again an underdamped waveform. As you say, it takes around 4 to 5 bits before it comes to the usual waveform of the baseline or mean arterial pressure before it comes to that. Why it happens? Again, stiff tubing, stopcocks, patient factors like patient is tachycardic, high cardiac output, hypothermia, etc. can cause this abnormality. Here, the map again will be same, but you will have a very high systolic peak with a low diastolic peak. So the map is compensated, which can be normal, similar to the usual arterial waveform, but the the demonstration looks like the patient has a very high systolic blood pressure, which is erroneously reading. So optimal damping is 1 to 2 oscillation before it comes to mean. Underdamped more than 2 oscillation, overdamped less than 1.5 or 1 oscillation. Okay. Now there are a few other waveforms that you need to know about. Looking at the arterial waveform, you can anticipate what type of abnormality the patient is having. There are different type of pulses described in the literature. Not very important in terms of ICU exam, but sometimes the examiner may be fond of asking what do you mean by this terminologies. The first one is pulsus alternans. So you'll have a normal waveform followed by a damped waveform, normal waveform, damped waveform. So amplitude varies with each beat. This is usually seen in arrhythmias, what type of rhythm, whether it is a good rhythm or bad rhythm, if there is arterial kick or not. And number 2 is left ventricular failure or dysfunction. So patient can have one beat with a good ejection, the other beat with a low ejection. So indirect signs of good and bad ventricular contraction that can happen with arrhythmias and left ventricular failure. Pulsus bisferens, which will have 2 systolic peaks, usually seen in aortic regurgitation and also in HOCM, you can see, or hyperdynamic circulation such as hyperthyroidism. So 2 systolic peaks, Bisference can be seen in these three conditions. Pulsus paradoxus. So this is important to know because this is more clinically focused in case of ICU setting. What happens is we usually have if the patient is spontaneously breathing, we usually have a drop of less than 10 millimeter of mercury in the systolic blood pressure. But if this drop is more than 10 millimeter of mercury, so more than normal, then it is called as pulsus paradoxus. So this is actually erroneously called, but usually there is a fall, spontaneous breathing. But if the fall is more than 10, then it is pulsus paradoxus. As you see, this is inspiration. The systolic peaks have come down significantly by more than 10 millimeter of mercury. So this is pulsus paradoxus. This can happen in cardiac tamponade, constrictive pericarditis, COPD, hypovolemic shock, severe pulmonary embolism, and severe asthma. The bottom line is, if there is a significant pressure difference, intrathoracic pressure difference, then this gets exacerbated. So when will it happen? Anything that causes a significant pressure difference in the intrathoracic cage or in the cardiac, what you call pericardium, which is tamponade pericarditis, COPD with air retention, severe asthma with air retention, pulmonary embolism with restriction of the movement of the ventricles, and hypovolemic shock, where you don't have much blood going into the heart with these changes in the intrathoracic pressure. So anything that causes intrathoracic and intracardiac pressure changes significantly can cause a pulsus paradoxus, which is the important finding in tamponade. The reverse pulsus paradoxus, again hypovolemia, you'll have a significant stroke volume variation if the patient is hypovolemic, and the percentage of stroke volume variation or a pulse pressure variation will tell you whether the patient is hypovolemic and fluid responsive or not. Something called as a pulsus parvus, which is again a bad thing. So weak pulse and weak pulse pressure. So this can happen in aortic stenosis, very narrow pulse pressure, left ventricular failure, and shock. So important thing to know about is pulsus paradoxus. This is a PA catheter tracing. You may or may not get it, but as an instrument in a cardiac center, if you are posted for the exam, then there is a good probability that you will get it. So you need to know a few things about the PA catheter. In this case, I'm just talking about the waveform, but as I said yesterday also, you may need to know what are the indications for PA catheter, what are the uses for PA catheter, what are the complications, and what are the evidence behind it for use or not using it. In this stage, I'll just talk about the waveform, how you see in a PA catheter. So first of all, look at where the PA catheter is and where the waveforms are. So if the PA catheter is on the right atrium while putting it, you will have a CVP waveform. Once it goes to the right ventricle on this, you will have a ventricular waveform where you will have a systolic, if it is normal, somewhere between 15 to 25, but the diastolic comes to 0. So that's the important thing to look. This is like a ventricular waveform with a diastolic pressure of 0. So that means the catheter is in the right ventricle. Now the balloon is inflated and it goes floated into the right, into the PA pulmonary artery. That's where it becomes like a arterial waveform where you'll have a systolic and a diastolic number. Systolic will be whatever it is there in the ventricle should be, and the diastolic goes from 0 to around 8, 7, 6 like that. Okay, you will have a more of an arterial type of waveform picture. That means you are in the PA. You are still in the PA, you push, and then you inflate. The balloon gets engaged somewhere, and that's when you have an inflated balloon which measure the pressure distal to the catheter, not on this side. It measures the pressure distal to the catheter, which again looks like a CVP waveform, but it corresponds to the left atrial pressure. So this is the right atrial pressure to start with, ventricular pressure, aortic pressure, left atrial pressure, or pulmonary capillary wedge pressure we say. Okay, so that's how you note where the tip of the PA catheter is. So they can show you one of the waveform and ask you where do you think is the tip of the PA catheter. The trick to remember, if it is between 0 to 10, as you can see, and a CVP like a waveform, it is in right atrium. If the diastolic is 0, it is in the right ventricle. If it looks like a arterial waveform with a systolic and systolic being somewhere higher than 20, and the diastolic somewhere higher than 7 and 8, that means it is a pulmonary artery pressure. And if the number here looks like a wedge pressure waveform, it represents a left atrial pressure. All right, but this is not not the whole of PA catheter. You need to talk about or need to know about other parts, as I mentioned. I will leave that for your reading. CVP waveform, again, there are different waveforms in the CVP. So AC, X, V, and Y. So there are 2 negative and 3 positive waveform. A, C, and V are positive, X and Y are negative waveform. What does it represent? They may show you, they may give you a paper with a CVP waveform and ask you what are the waveforms or what are the peaks and what does it represent. So it's better to know about it. So A represents the atrial contraction, which is almost at the middle of the P wave on the ECG. The C represents the tricuspid valve elevation into the right atrium. So what happens is, atrium with the blood contracts, the blood goes through the tricuspid valve. So due to the contraction of the atrium with a closed tricuspid valve at the initial stage, there is a peak. So this is called as A wave. Once it goes through, the blood goes through the tricuspid valve, and then the ventricle starts contracting with a closed tricuspid valve. That's where you get a C wave. So tricuspid valve elevation into the right atrium. So right ventricle contracts, it pushes the tricuspid valve into the right atrium, causes another pressure wave, positive wave, which is called the C wave. And then the tricuspid valve opens. There will be a drop in pressure, which is downward movement of the contracting right ventricle that can that can lead to pressure difference or decreased pressure in the right atrium, causing the X descent. Then the blood starts filling in to the right atrium from the vena cavas. Then you will have a positive wave, which is called as the V wave. And then the tricuspid valves open in the ventricular diastole, causing the Y descent. So that's where the tricuspid valve open, not here. So this X descent is due to the downward movement of the contracting ventricle. What happens is, once the ventricle starts to contract against the closed tricuspid valve, initially the tricuspid valve moves into the atrium, causing a peak, which is C. But again, due further contraction causes the ventricular size to come down, and the pressure drops in the right atrium, causing the X descent. Okay. So you need to know the physiological reason why you have these waveform. A for atrial contraction, C for tricuspid valve elevation because of the contraction of the ventricle. X descent is due to the contracting ventricle, which pulls the atrium down, causing decrease in pressure. Then V is the back pressure from filling of the blood from the top end, and Y is the tricuspid valve opening in the early ventricular diastole. It is important to know because the abnormalities, particularly in the X and Y descent, will represent what type of abnormality the patient has. So first of all, loss of A wave can happen in atrial fibrillation flutter, where we will not have any A waves, that is pressure transmitted. But sometimes that can also lead to another abnormality called as Canon A waves. What happens is, if there is dyssynchrony between contraction of the atrium and the tricuspid valve doesn't open at the same time, so the atrium is contracting against a closed tricuspid valve, that can cause an acute rise in pressure in the atrium, causing a peak A wave called as Canon A wave. That's what it is. So here the atrium is contracting with a closed tricuspid valve, causing a pressure. The A wave becomes called as Canon A waves. Can happen in junctional rhythm, where there is no synchrony between atrium and ventricle. The atrium keeps on contracting even if the tricuspid valve is closed, or in AF also, where the atrium keeps on contracting without the tricuspid valve being open. You can see here the CVP waveform and Canon A wave, junctional rhythm. So the A and V are not synchronous. Atrium and ventricle are not synchronous. Atrium is contracting with a closed tricuspid valve. So you'll have a peak here, like a Canon A wave, like that. But once the patient goes into sinus rhythm, as you can see, there is P waves now. That Canon wave gets down because atrium is contracting and the tricuspid valve is opening at the same time. So there's no upshoot of pressure like that. So loss of Canon A wave here because the patient becomes sinus. Same thing. Tricuspid regurgitation. Anyone, what sort of abnormality you will see in a CVP waveform in tricuspid regurgitation?
Large CV wave.
What is it called? What sort of sign it is called as? Square root sign. You'll get a CV, fusion of C and V wave happens, causing CV waveform or square root sign, like a square root sign you'll get. Tamponade, what you will get? Anyone? So what is lost here? Tamponade? The Y descent is lost, right? So this is a normal X descent and Y descent. The X descent and Y descent is normal, but in case of tamponade, you lose the Y descent. Okay. Now in constrictive pericarditis, you will have abrupt X and Y descent. So very stiff X and very stiff Y descent. Characteristics of constrictive pericarditis. Now, how to remember tamponade? Forget about cardiac. Tamponade is one word, so you will lose one. Y will be gone. Okay. Absence of Y descent is tamponade. Your X and Y descent both become very stiff or very straight. So constrictive pericarditis is stiffness of the cardiac pericardium. Stiffness goes to stiffness of X and Y descent. So very stiff X and Y descent that happens in constrictive pericarditis. Now physiology of that is complicated. You have to read why it happens. But remember that tamponade has one Y descent absent. Constrictive pericarditis is stiff Y and X and Y descent because the cardiac chambers become stiff. All right, few things about ICP monitoring. This is important in the exam because if you're placed in a neurosurgical or a trauma unit, they can ask you about this. What's the normal ICP? Is usually around 5 to 10 millimeter of mercury, but it varies differently at different position. Physiological range can be up to 50 millimeter of mercury if the patient is acutely coughing or sneezing. Okay. Indication of ICP monitoring is an important question in the exam. So we go by the Brain Trauma Foundation. So there are three major indications for monitoring ICP. One is any trauma patient with a GCS of 3 to 8 after resuscitation and has an abnormal CT brain. So 3 to 8 GCS and abnormal CT brain with severe TBI. So this patient has abnormal CT brain and a low GCS. They will have a ICP monitor straight away. But if the patient has a severe TBI with a normal CT scan, in that case, they need to have two or more of this. So age over 40 years, unilateral or bilateral motor posturing, and systolic blood pressure of 90, less than 90. So out of these three, two has to satisfy if the patient has a normal CT brain after a traumatic brain injury or GCS of 3 to 8 with abnormal CT scan. So anyone coming to you with a low GCS less than 8 and a bad CT scan, straight away ICP monitor. If anyone comes to you with a low GCS but a normal CT scan, then you have to look for two out of these three. age more than 40, bilateral or unilateral motor posturing, and blood pressure less than 90. Clear? Evidence behind it. So there is, interestingly, not many trials, randomized controlled trials, which has looked at the use of ICP and looked at the ICP directed management and outcome of the patient. There was a landmark trial called as the Chestnut trial or by Chestnut trial. So they looked at, it is a North American trial. They looked at around 320 patients. Half of that almost are ICP monitored and half of that were managed with imaging. They were looking for 6-month mortality. They found that there is no significant difference in mortality if you monitor the ICU or don't monitor the ICP and or don't monitor the ICP and just go by radiological finding. Okay. But they found that there are some favorable outcome with there is, what do you say, less. So if you monitor the ICP, the ICP stays within normal range because of the intervention. If you don't monitor the ICP, there is no point saying that the ICP were normal. So that means they said that in the monitored group, they have maintained normal ICP for a longer duration of time because they were monitoring and were treating the patient accordingly. The other way around, in the non-monitored group where they looked at imaging only, they don't have any data that the ICP was normal or not. But basically, this randomized trial found that they did not support that ICP monitoring is going to change the outcome of the patient. But again, this is widely criticized because it is done only in the North American countries. And the standard of care is ICP monitoring in a traumatic brain injury. You cannot do a trial nowadays in a advanced setup where we'll say that 50 of the patient will not be monitored for ICP and 50 of the patient will be monitored for ICP because it is a standard of care. Now you cannot do that. Yes, you can do like one hospital which does not use any ICP monitor and does neurosurgical or neurotrauma patient compared to a center where regularly ICP monitor is used and managed patient accordingly. You can compare those two hospitals, but again there will be very disparity of results. So it is very hard to do a current trial on this. But whatever literature we have is a randomized trial which looked at ICP monitoring and management accordingly, and usual radiological monitoring and management accordingly did not find any benefit of it. But they found that ICP were within 24 in a longer period of time in patients who were monitored because they had a monitor and were treated for it. Doesn't make any difference. Then there were three retrospective studies in America which looked at patient management and with or without ICP monitoring, registry data analysis, and they found that when the ICP monitor were used for management of these neurotrauma patients, they had a decreased 2-week mortality post-injury. So the majority of the recommendation that comes from the Brain Trauma Foundation is based on these papers, and they gave a level 2B recommendation saying that management of severe TBI patient using information from ICP monitoring is recommended to reduce the in-hospital and 2-week post-injury mortality based on these 3 or 4 trials. Now waveforms, so you can see in this picture, this is the ECG, the green one, the red one or the pink one is the arterial waveform, and the white one is the ICP waveform. Okay, so you can see there is clearly demonstrated 3 peaks in the ICP waveform. We call it as a peak 1, peak 2 and peak 3, P1, P2 and P3. P1 represents the percussion wave, which is representing the arterial pulsation. P2 represents the tidal wave, which represents the intracranial compliance, and P3 represents the dicrotic wave, represents the venous pulsation. So if you have a decreased intracranial compliance, this P2 will be going higher up than the P1. So that's the only information that you get from a ICP waveform. When P2 becomes higher up, that means you are in trouble. The ICP or the compliance is getting worse. All right. Now different phases. So this is normal, P1, P2, P3. Here, if you have hypotension, then your perfusion gets down and you can have some changes. But the most important thing is this one, where P2 becomes more than P1, where there is increase in pressure in the brain, which can be due to a space-occupying lesion, bleeding, edema, etc. And this the last one, where you don't have a skull. So if you have craniectomy of the patient, you don't have a skull on top of the brain, and you have put a monitor into the brain, then it will not have any waveform, because there is no no reflection of the waveform to represent this waveform. Okay, but if you put your hand and give some counter pulsation, then it can change to this type of waveform. There's something called as a Lundberg wave. So there is usual respiratory variation in each individual waveform. So this is one waveform, P1, P2, P3 in each one of them. And there is a usual respiratory variation with respiratory cycle. The waveform goes up and down, similar to the arterial waveform. We call this something called as a Lundberg pattern. So each of these spikes is one wave. And look at the time through which the waveform is maintained. So you can see the A wave pattern is at a ICP of 50 millimeter of mercury. The B wave is around 20. C wave is less than that. So A is abnormal. So this is more of a plateau shape. 50 to 100 millimeter of mercury lasts for 5 to 20 minutes, suggestive of decreased brain compliance, high pressure in the brain. This pattern. B wave is rhythmic oscillation, amplitude is less than 50, occurs every 1 to 2 minutes, less useful clinically, doesn't have much of a meaning, suggestive of low brain compliance. Again, it can be getting from B to A. If it goes from B to A, is bad prognosis. C is the usual waveform we get in a person where there is rhythmic oscillation less than 20 millimeter of amplitude, occurs every 4 to 8 minutes, synchronous with spontaneous variation with blood pressure, which is non-pathological. So Lundberg C is normal. They can ask you about this. So what do you mean by Lundberg pattern? A, B, C. A is abnormal, grossly abnormal 50. B, unsure of the significance. If it gets worse, B can transform to A, but C is the usual normal one. Now, what are the techniques of ICP monitoring? There are different devices that is used. You can classify them. So invasive are external ventricular drain, microprocessor like ICP monitoring devices or Codman catheter, which can be fiber optic catheter. You can use strain gauges and pneumatics. So usually in clinical practice is the EVD is the gold standard, which is usually used intraventricular drain or external ventricular drain. Then microprocessor ICP monitoring are the Codman catheter, which are intraparenchymal catheters, which can be placed into the parenchyma and directly get pressure from that. Rest of them, fiber optic, strain gauge, pneumatic. Pneumatic is more experimental. Fiber optic is more coming up nowadays. Non-invasive measures that can be used is a transcranial Doppler, which can look at the velocity changes in the middle cerebral artery, and based on that you can anticipate how tight is the brain or not. Tympanic membrane displacement, again experimental stage. Ultrasound, so optic nerve sheath diameter, very diffuse outcome of this. So we know that there is a normal optic sheath diameter and what is the range that can be, but very operator dependent and practice dependent. So, and it is not a continuous measurement that you can see on the monitor. Every time you have to do it intermittently. MRI and pupillometry. So MRI are indirect evidence of brain edema and brain tightness, and pupillometry is again indirect to look for the pupillary size. So these are the non-invasive modalities. So whenever they ask you what are the modality for ICP monitoring, that can be invasive, non-invasive, talk about invasive in the list and non-invasive then. It will be more impressive as an exam. And if you are in a neuro center and if the patient has a EVD, 100% your VIVA would include the EVD. So external ventricular drain is the gold standard. Catheter is placed in one of the ventricles of non-dominant hemisphere through the burr hole, usually through the right side for a right-handed person. Catheter connected to transducer with a ICP monitor. It is very commonly used, low cost associated with it, gold standard reliability, and it can be used as a therapeutic measure by draining the CSF. And the success rate of putting it is around 80%, which is pretty significant or important. It can also be used, as I said, for drainage of ICP. Complication that can happen, so malposition up to 20%, occlusion of the catheter that can happen, hemorrhage in the tract, noted to be up to 15% cases, but usually asymptomatic. The most important complication that is associated is infection. The rate of infection increases as the catheter stays for longer period of time, and particular pathology, if there is blood in the brain like intraventricular hemorrhage, subarachnoid hemorrhage, CSF leak, all these can complicate with infection. Okay, the infection rate can be reduced by external tunneling into the scalp, and that can reduce it, but there is no role of prophylactic antibiotic in reducing external ventricular drain induced ventriculitis. Okay, there is some use of antibiotic impregnated catheter has reduced the infection, but very, very costly. Now, they can ask you about treatment for ventriculitis. Standard answer is I'll go by the hospital antibiogram. My hospital uses vancomycin plus ceftazidime with a dose of 20 to 25 milligram per kg, followed by load and followed by 15 to 20 milligram of kg with therapeutic drug monitoring every 8 to 12 hour dosing. And ceftazidime 2 gram IV 8 hourly, then modify to the organ dysfunction the patient has. If he has the renal failure, then you have to modify the dose. Other alternative are vancomycin plus cefepime or vancomycin plus meropenem. So gram positive and broad spectrum gram negative cover. Microtransducer processor, very, very helpful. So this is the Codman catheter that we use. So they are convenient to place. They are intraparenchymal usually, but can be placed in any other chamber. The advantage is can be inserted in various compartments of the ventricle, parenchyma, etc. Easy to place. Nowadays there are MRI compatible ones also, but the problem comes with zeroing. It can only be zeroed once, but nowadays the new transducers can be repeatedly zeroed. Number one. Number two is infection rate is much less than that of the external ventricular drain, so it is preferable in some cases. But disadvantage is again it drifts. So because of fibrosis, tissue changes, edema, because it is in the tissue, the pressure measured can be different at different time, and it gradually drifts from the baseline. So accuracy is a questionable thing. Bolt again very rarely used. They go into the subarachnoid space. Very traumatic procedure, so usually not used in the clinical setting. Pneumatic devices are experimental. They are called as the Spiegelenberg parenchymal transducer. They are an air pouch at the tip is maintained at constant volume, and the changes in that air pouch will tell you the pressure with a transducer. Again, experimental, but has good correlation with changing dynamics of ICP. Non-invasive monitoring, usually optic knob sheath diameter. We take it as a 5 millimeter as a standard as normal. And then if there is an increase from that, that means that the ICP is changing or increasing. And usually the size should reduce by a particular number with the ICP controlling measure, should come down by 0.6 with the measures. But again, you can see the time frame. Within 2 hours, the brain can be dead with a high pressure. So repetitiveness, operator dependent, so has its own limitation. Transcranial, we talked about that. Optic knob sheath, we talked about that. So they can ask you what are the demerits of these methods, non-invasive. So first of all, they are not gold standard. They're not continuous monitoring and very operator dependent. Papilloedema, again, you need to know some signs of papilloedema and what the normal optic disc look like. Again, it will be a spotter. It will not be a bedside question that will be asked. Usually, features of papilloedema in the bedside is you'll have a blurred optic disc margin, as you can see. Optic disc margin is blurred. Elevated optic disc with swelling, which is again a practical thing to look with the fundoscopy. There will be loss of venous pulsation, which is abnormal, and you will have engorged and retinal tortuous retinal vessel compared to the normal. You can see there are more tortuous compared to a normal optic disc. So this is again an indirect evidence of raised ICP with papilloedema. All right, that completes my session. Thank you for listening, and if you have any other questions, I'm happy to answer. All right. If you guys don't have question, I think there was a couple of questions in there. What is it? Sir, double triggering and premature cycling occurs at the same time. It can happen. One can lead to the other. So if it is a premature cycling, then it can cause double triggering. So have that idea that it can coexist together. What else? Yeah, I think that's the last question that I had. So that completes my session. I will ask Dr. Bhuvana is doing the next one, I
Yes, sir.
believe.
I'm doing the next one. Yes, yes.
Okay, thank you. And I'll hand over the teaching to her. Thank you.
Thank you, sir. Good evening, guys. Yesterday's session was good. Like many people were interacting, they were answering questions. It was a good session yesterday. I wish today also you people can participate, answer a few questions, seeing the pictures. So we'll be discussing about cardiac monitoring devices today. The importance of this in an OSCE session would be they might be, if it is a very active cardiac ICU, they might be showing you the devices and can ask whether it's a static or a dynamic device, and what sort of device it is, which mechanism based it is functioning, and what are the complications, limitations, and how do you measure a continuous cardiac output, and the indications for it, contraindications, all of that. So this could be a common question if you are attending your Viva in a very active cardiac ICU center. Okay, so we'll be discussing a bit of a theory, that's true, but I'll be showing you the pictures and possible OSCE pictures where you can interact and answer. Let's see how it goes, okay? So can someone tell me what is the indication for using the cardiac output devices? Why do we use the cardiac output devices? We have arterial line, we have non-invasive monitoring, we have many things. And why do you want to use cardiac output devices? What are the main indications for it?
In case of undifferentiated shock or severe shock, refractory shock,
Yes.
to guide the therapy in undifferentiated shock.
Yes,
In case
that's
of
true.
cardiac surgery.
Great. Yeah. Mainly in cases of undifferentiated shock. For example, it is a multifactorial shock where you don't know, like you are only seeing one aspect of it. You want to see and protocolize the management using the cardiac output monitoring, hemodynamic monitoring. Then that cardiac output monitoring device would be a best method to go ahead. When there is a deranged cardiac function and shock where you want to titrate fluids, inotropes, and vasopressors, when you want to do a goal-directed resuscitation in a multifactorial shock states, and especially, as Soumya said, in a perioperative monitoring in patients who are undergoing cardiac surgery, non-cardiac surgery, and major abdominal procedures. In such cases, these cardiac output monitoring devices would be helpful. And in cases of protocol-driven management, like you are creating an algorithm driven by the cardiac output data to support the management decisions in an hemodynamically unstable patient, then you can use the cardiac output monitoring device. Okay. So, how do you classify the cardiac output devices? Based on what, and what are the different methods of classification? Can anyone?
Invasive, non-invasive, and invasive, or we can calibrate it or non-calibrate.
Correct. That is one method of classifying it. We can also classify the cardiac output devices based on the principles, principle using which they function. Okay. The commonest one is the fixed principle, where the pulmonary artery catheter uses this principle to detect the cardiac output. So what is fixed principle? It is basically the total uptake or release of the oxygen by the lungs is the product of the blood flow through the lungs and the arteriovenous oxygen difference. This is one principle based classification. Second, arterial waveform analysis techniques. Like any method that uses the arterial waveform or the pulse contour or the pulse power or pulse wave analysis, then we can call it as an arterial waveform analysis based devices. Then comes transthoracic impedance and bioreactance, which includes some of the non-invasive devices called bioreactance and bioimpedance. Then comes Doppler principle, where esophageal echo mainly functions using this principle. Then comes the most important technique, that is the indicator dilution technique, where thermodilution, pulse dye densitometry, lithium dilution techniques, where devices function using this methodology. So this is one way of classifying the cardiac output devices using the principles: fixed principle, arterial waveform principle, transthoracic impedance bioreactance, Doppler principle, and indicator dilution techniques. This is one way of classifying it. Yeah, and the second way is that, sorry, 1 minute. Yeah, second way is that whether it's an invasive device or a non-invasive device, whether it's a calibrated device or a non-calibrated device. Okay, so when we see the invasiveness of the device, we can classify them into invasive, minimally invasive, and non-invasive. The invasive is the pulmonary artery catheter. The minimally invasive are the ones which uses either a pulse wave analysis technique with thermodilution or a Doppler principle. And the non-invasive ones are the impedance, the reactance, the ECOM, the pulse wave transit time, and the NICO. These are some of the non-invasive devices. So, can someone tell me what is calibration and what is a calibrated device? What is an uncalibrated device? Like, what is the concept you understand by that?
Calibration is externally we do it, ma'am, just to avoid any bias when we are continuously monitoring any parameters. Just to obtain like accuracy and like precise information from the monitoring. Uncalibrated is based upon the like normograms, patient data. It will have some formulas, inbuilt formulas, which will to prevent the bias.
So, correct. Uncalibrated is correct. For calibrated, I'll just add an additional information. Like if you take pulmonary artery catheter, how do you obtain cardiac output? You inject a cold saline, and then it is detected by the thermistor, and then area under the curve comes, and then the Steward equation comes, and from which the cardiac output has been derived. So it is kind of a static parameter. Whenever there is a gross hemodynamic change in the patient, like for example, increased vascular resistance, decreased vascular resistance, or the hemodynamic instability happens, or vasopressors go high enough, you can again do the measurement of the cardiac output by injecting the cold saline. But when it comes to these devices, like the minimally invasive devices, like Pico Plus, Volume View, Litco Plus, etc., they use two technologies. One is transpulmonary thermodilution technique. Along with that, they are also using a pulse wave analysis. Let it be dynamic tone technology, let it be pulse power analysis, let it be pulse wave analysis. So that pulse wave analysis is the one which is giving us a continuous cardiac output monitoring. Right. So if you see the pulse contour devices, they don't measure the flow. They only interpret the arterial pressure waveform for a continuous cardiac output. And these arterial pressure waveform can be influenced by various reasons, based on vascular resistance, the stiffness of the vessel, the compliance of the vessel, or the physiology of the patient. So when the pulse contour devices can be influenced by many things, we need a reference value. We need a baseline value. So we use a transpulmonary thermodilution technique to get a reference value. And by using a patient-specific conversion factor at that particular point of time, the continuous cardiac output monitoring continues. Okay. Whenever there is a gross change, suddenly the noradrenaline is increasing, suddenly the hemodynamic status is going down, we need recalibration. We cannot say that whatever waveform is present in the monitor is giving us the correct cardiac output value, because it can change based on the complaints, the stiffness, the vascular resistance. So when the devices, when the arterial pressure waveform based analysis can change because of various reasons, then we cannot think that whatever is seen in the monitor is a correct value. So we need some reference value, a baseline value, to see whether the cardiac output measured is syncing along with the reference value, so that a continuous monitoring can be reliable. So that is why we do calibrate the devices. Okay. When you see the calibrated devices, the most common minimally invasive calibrated devices are Pico Plus, Litco Plus, Volume View. As she rightly said, we have to externally calibrate these devices. And some of the uncalibrated, or what we can tell is a self-calibrated devices, are FlowTrack, Litco Rapid, and PRAM. These are some of the uncalibrated or self-calibrated devices. Based on the patient-specific nomograms, they adjust and calibrate themselves. Okay. So this is how you classify the cardiac output monitoring devices as invasive, minimally invasive, and non-invasive, where during OSCE Viva, the pulmonary artery catheter, this Pico volume U catheters and FlowTrack could be the areas of interest, and bioimpedance and bioreactance again. Okay. So this is a picture showing the devices which could use various pulse contour analysis. Let it be area under the curve by Pico, let it be pulse power analysis by Litco, or let it be a dynamic tone technology by means of flow tracker Vigilio. So these are some of the methods which uses the arterial pressure waveform, the pulse waveform analysis. Okay, you have to remember this. They may ask specific methodology or mechanism through which the cardiac output device is functioning. So this we discussed. So basically calibration is performed to eliminate or reduce the bias in continuous measurements. Basically it tells us whether the cardiac output measured is precise as well as it is accurate. And non-calibrated techniques, they usually use a pre-programmed correction factors in the device. It is a nomogram scaling factor based on the patient's age, gender, height, and weight, and equation correction factor based on measurement characteristics. So the examples for that are FlowTrack. Okay. Okay, let us start the discussion about the devices. One first is the invasive device. So can someone tell me what catheter it is?
Pulmonary artery catheter.
Yeah, it is a pulmonary artery catheter. So how are we going to identify it? Usually it is one of the longest catheters, 110 centimeters in length and 7 to 8 French in caliber. That is a common adult size we use. And the catheter is made from a polyvinyl chloride material that is pliable at the room temperature and softens at the body temperature. And you can see the markings. It is usually marked at 10 centimeter intervals, where you can guess, if you take the catheter and see, it will be 10 centimeter markings. So 110 centimeter and 10 centimeter interval markings will be a clue to identify the pulmonary artery catheter. So how do we insert it? It is like inserting a central venous catheter, but you are seeing a waveform or seeing the pressure waveform, how in each chamber, how the waveform changes, which Dr. Sananta just discussed. And what are the indications for a pulmonary artery catheter is mainly for cardiac output monitoring. You can also make it as a continuous cardiac output monitoring by inserting a tungsten filament, and it can continuously sense the thermistor temperature changes and give us a continuous cardiac output monitoring. It can also be used for central temperature monitoring. If you want to measure the pulmonary artery pressure, then yeah, PAC is one of the good methods. If you want to measure the mixed venous saturations for any protocolized hemodynamic management, then PAC can be used. And it can also be used for the estimation of diastolic filling of the left heart. So if you see the parts of the pulmonary artery catheter, you can see that usually it is 4 to 5 port catheter. So you can see the yellow colored port where it is the catheter tip which monitors the pulmonary artery pressure, and you can also take the sample for the mixed venous oxygen saturation. So this is the distal lumen, usually through which you take the sampling and it measures the pulmonary artery pressure. The second one is the blue port, which opens at the 30 centimeter proximal from the tip, which is mainly for monitoring the central venous pressure. and you can also use it for fluid and drug administration. Okay, and the third lumen, which is the red lumen, is the balloon lumen, which leads to the balloon near the tip with the locking port, and it is used for inflation and deflation of the balloon during insertion. And the fourth lumen houses wires that lead to a temperature thermistor just proximal to the balloon, which monitors the pulmonary artery temperature during the thermodilution for cardiac output monitoring. And the fifth port could be there, could not be there, which can be used for right ventricular infusion port or for the pacing of the right ventricle. Okay, so these are the common ports which you can see in pulmonary artery catheter. And as Sir told, like when you are inserting the pulmonary artery catheter in various chambers and location, the waveforms varies. When it reaches the initial right atrium, you can see this AV wave. And when it reaches the right ventricle, you can see a systolic and a diastolic wave. And and when it reaches the pulmonary artery, you can see the diastolic wave getting disappeared and only systolic waveform you can see. And once you wedge the pressure, you can again see the A and V wave. And ideally, the pulmonary artery catheter tip should be located in the zone 3 of the lung, where the pulmonary arterial pressure is more than the pulmonary venous pressure, which is more than the alveolar pressure. Okay. And in an X-ray, so in an X-ray, you can see that the tip of the pulmonary artery catheter should be below the level of the left atrium within 2 centimeters of the cardiac silhouette. And another technique using which you can confirm the position is the blood aspirated from the tip of the catheter should show value nearly similar to the arterial blood gas values. So what is the mechanism through which the pulmonary artery catheter functions? It is the Fick's principle. Okay, as I already told you, it measures the oxygen consumption and the arteriovenous oxygen content difference. So how are you going to do this? You're going to inject a 10 ml of cold saline through the proximal lumen into the right atrium. The temperature decrease in the blood measured by the thermistor in the pulmonary artery. And there is a thermodilution curve, which is plotted by the computer connecting the catheter. And the area under the curve is detected, which is inversely proportional to the pulmonary artery flow. And the cardiac output is determined by the Stewart-Hamilton equation, which we will discuss in the next slides. So as I already told you, we are injecting a cold saline, which is being detected by the thermistor in the pulmonary artery, and you are getting an area under the curve. If suppose the curve is narrow, that means there is high cardiac output. If suppose the curve is wide and broad, then that means it is a low cardiac output, and it is inversely proportional to the flow in the pulmonary artery. Okay, and 3 such readings are taken and averaged. So cardiac output and other indices are derived using the thermodilution curve generated using Stewart-Hamilton equation. So what are the parameters you are deriving out of the pulmonary catheter? The cardiac output, cardiac index, stroke volume, and stroke volume index. You can also detect systemic vascular resistance, pulmonary vascular resistance, left ventricular stroke volume index, right ventricular stroke work index, and pressure measurements like right atrial pressure, right ventricular pressure, pulmonary artery pressure, pulmonary capillary wedge pressure. And you can also derive oxygenation parameters like mixed venous oxygen saturation, oxygen delivery, oxygen consumption, oxygen extraction ratio. So the main limitations with the pulmonary artery catheter is that somehow, like there could be loss of injected temperature, temperature variations, thermistor defect, clot formation at the catheter tip, and catheter deviation and obstruction. Some of the patient-related factors are intracardiac shunting, severe tricuspid valve regurgitation, significant arrhythmias, or abnormal respiratory pattern, and low cardiac output states. The main clinical limitations are it requires a specialized training for insertion and interpretation. Usually, a pulmonary artery catheter is intermittent measurement. We have to attach a specific device for a continuous measurement. There could be some time delay between the injection and the measurement. What are the common complications associated with pulmonary artery catheter? Insertion-related, the venous access complications, arrhythmias, heart block, and cardiac perforation can happen. With respect to the vessel, there could be pulmonary artery rupture, pulmonary infarction, pulmonary hemorrhage. With respect to the catheter, there could be catheter knotting, balloon rupture, thrombosis, embolism, and catheter-related bloodstream infections can happen. With respect to the cardiac structures, there could be risk of damage to the cardiac valves, endocardial damage, and tricuspid regurgitation could happen. So the ideal time to keep the pulmonary artery catheter would be 48 hours to 72 hours maximum. Okay. If you see the evidence for the pulmonary artery catheter, I have just mentioned the important trials like the Pac-Man trial, which showed no benefit or harm using a pulmonary artery catheter in ICU for hemodynamic monitoring. Escape trial was in specifically heart failure patients. Like it didn't show any superiority with other methods when it is used for hemodynamic monitoring. And FACT trial, of course, in ARDS, there was no major mortality benefit by using a pulmonary artery catheter in ARDS patient for hemodynamic monitoring. These are some of the named trials which says that there is no superiority by using a pulmonary artery catheter when compared to other cardiac output monitoring devices. Okay. So next we will move on to minimally invasive devices. First, we will take the indicator dilution techniques. Okay, the transpulmonary thermodilution technique with pulse wave or a contour analysis or pulse power analysis. So can someone tell me which monitor is this? Like, of course, the name is mentioned. Like, which monitor is this?
EV1000 volume view.
Volume view. Yes, very good. So this is a picture showing volume view where if suppose it is a center which does not have these devices, they may show pictures to you where you may have to detect using the picture as well as the monitor. This is the image showing Pico Plus. I'll explain you the parts once we discuss the theory. So as we already discussed, the main mechanism through which these devices function are the transpulmonary thermodilution technique along with a pulse wave analysis technique where it gives us the continuous cardiac output monitoring. Okay, here we need a central venous catheter for cold saline injection and an arterial catheter with an integrated thermistor at the tip of the femoral, axillary, or brachial artery, and a monitor unit for continuous pulse contour analysis and intermittent thermodilution, and temperature sensor to detect the blood temperature changes. These are the device components. And in general, you have to calibrate the device if the device is idle, even with no major hemodynamic instability. If the device is idle for like 6 to 8 hours, it is better to calibrate once in 8 hours. And whenever there is an hemodynamic instability, like sudden increase in the vasopressors or disconnection of the devices or like sudden change in the hemodynamic physiology, then you have to calibrate, because that is when we will know whatever we see in the monitor is correlating with the baseline reference value, and it has been continuously we are monitoring in a correct way, like in a patient specific factor way. Okay. So if you see this picture, this is the sensor with continuous thermistor attached, and this is the specialized femoral artery catheter which you have to connect with the thermistor, and this is the thermistor manifold through which you are injecting the cold saline. If you see in this picture, you can see that there is a special femoral arterial catheter which is connected to the thermistor, and this is the thermistor manifold through which you are injecting the cold saline. So when you inject here, because of the transpulmonary thermodilution technique, the cold temperature is sensed in this femoral arterial catheter, and through the algorithm, it detects the cardiac output monitoring values, all the hemodynamic values. Similarly, in the Pico, you can see that there is a thermistor manifold and there is an arterial catheter which is specifically connected to a thermistor. And when you inject the cold saline, automatically it senses here, and based on the pulse contour for the continuous, and for calibration, it uses a transpulmonary thermodilution technique. So as we just discussed now, you are injecting a cold saline through the central venous catheter. The temperature change is detected by the thermistor in the arterial line, and the cardiac output is calculated using the area under the temperature time curve. So if you see this, the main values we get out of the transpulmonary thermodilution area under the curve is cardiac output, the global end diastolic volume, the intrathoracic blood volume, extravascular lung water, pulmonary vascular permeability index, cardiac function index, and global ejection fraction. And because after once you calibrate, once the pulse contour analysis comes, it continuously monitors the cardiac output. It gives us BP, heart rate, stroke volume, SVV, PPV, SVR, and index of left ventricular contractility. So these are the usual parameters we get because of TPTD and pulse contour analysis. So it uses a calibrated pulse contour analysis algorithm based on the arterial compliance and the systemic vascular resistance, and beat to beat arterial pressure waveform analyzed to calculate the stroke volume. And that is the reason we need this calibration, so that the waveform correctly indicates the cardiac output with respect to the reference value which we obtained during transpulmonary thermodilution. With the transpulmonary thermodilution, we get two important values, that is the extravascular lung water as well as pulmonary vascular permeability index. This could be asked in the OSCE, where the extravascular lung water, it quantifies the absolute amount of hydrostatic pulmonary edema. It represents the total lung water outside the pulmonary vasculature. Whenever the values are more than 15 ml per kg, it indicates pulmonary edema, which is an hydrostatic pulmonary edema. Okay. And the pulmonary vascular permeability index is the ratio of the extravascular lung water to the pulmonary blood volume, and it reflects the pulmonary capillary permeability. An elevated PVPI indicates increased alveolar capillary barrier injury, which helps us to differentiate between an hydrostatic versus ARDS kind of a picture. Okay. And any value more than 3 indicates a severe injury to the barrier. So what are the limitations when it comes to PICO and volume view? The technical factors could be any change in the aortic impedance, any change in the peripheral arterial resistance. This is very important. And presence of air bubbles or clots, or inadequate indicator of fluid temperature or volume could be some of the technical factors and limitations. What are the patient contraindications could be? If the patient is having severe valvular regurgitation, aortic aneurysm, significant arrhythmias, presence of an IABP, or if the patient weight is less than 40 kg, then usually it is contraindicated. And some of the clinical limitations are it requires a specialized arterial catheter. You should take an arterial catheter where you can attach with a thermistor fold, which senses the temperature, not like a normal arterial catheter. The kit itself is very costly, and not many centers could afford it. And accuracy is affected by the rapid temperature changes, and it requires frequent recalibration during hemodynamic instability, and less accurate in conditions with high vascular variability. Okay. And what are the common complications with respect to PICO volume view? The arterial line related, there could be thrombosis, ischemia, pseudoaneurysm formation, bleeding or hematoma at the insertion site, or adjacent structure damage. Central line related, there could be catheter related bloodstream infections, pneumothorax, hemothorax, or central venous thrombosis. Generally, device related complications could be air embolism during calibration, fluid overload from repeated calibrations, and equipment malfunction or calibration drift could be some of the general device complications. So this, can someone tell me what is this image shows us? Like, of course, it is the same area under the curve, but it is mentioned in the picture itself. So this is a picture showing the LITCO device. Actually, in LITCO, the common LITCO and the LITCO Plus is kind of a two calibrate device. I mean, externally, you have to calibrate by using lithium. But there is a device called LITCO Rapid, which is similar to FlowTrack device. So it doesn't need calibration like the normal LITCO. So just don't get confused with the names. So LITCO and LITCO Plus is two calibrate device, and LITCO Rapid is one thing like similar to FlowTrack. Okay, so this is a picture showing a LITCO device where it uses lithium dilution for calibration. Instead of using a cold saline, here we are using a lithium dilution for calibration, where 0.3 millimole lithium chloride is injected in the intravenous or a central venous catheter, and lithium selective sensor is there in the arterial line, which measures the concentration, and ideally it should be calibrated every 8 hours. And followed by that, it continuously monitors the cardiac output by using pulse power analysis. Same concept, because whenever a device is using a pulse, a wave, or a pulse contour, or a pulse power analysis, you should make sure that the device is calibrated every 8 hours. Because with hemodynamic instability, the arterial pressure waveform can change because of various reasons. So you need to have a baseline reference value. Using patient conversion factor, you can have a appropriate cardiac output value. That is the main goal of calibration. So the main limitations are, it is usually contraindicated with lithium therapy. Muscle relaxants with lithium is not a good combo, and in pregnancy you should be cautious, and it requires an arterial line. And what are the common complications? Arterial line related complications, and lithium toxicity could be a possibility, but it is very rare. So this also measures all the cardiac output values similar to that of the pico and the volume wave. Only difference is that we are using a lithium for the dilution. That's all, thermodilution. So next we will be discussing about flow track. If you see, this is the obviously for flow track we just need an arterial line attached to a thermistor, and the flow track is the catheter or the device which we use, and the monitor in which you see the values, it's called the Vigilio monitor. So flow track and Vigilio forms the same system, where flow track is the sensor and Vigilio is the monitor. Okay, so it measures the cardiac output using pulse pressure analysis, where the system samples the arterial pressure waveform at 100 hertz over 20-second intervals, generating 2000 data points. And all you need is a standard arterial line and a transducer connected to a Vigilio monitor, and no calibration required. So it measures most of the cardiac index, like cardiac output, cardiac index, stroke volume index, and SVV and PPV. The main limitations are arrhythmias, aortic regurgitation, IABP, and mechanical ventilator changes. Only arterial line related complications are expected in this device. The next device is the PRAM, that is the pressure recording analytical method, where there is a mathematical analysis of arterial waveform morphology, where it analyzes the pressure variations during the entire cardiac cycle. It measures during the systole as well as the diastole, and it calculates the impedance and the arterial compliance. There is a beat to beat measurement, and the main limitations are arrhythmias, very low cardiac output, and damped arterial waveform, and arterial line related complications are expected. This is also one of the uncalibrated devices. Next comes the minimally invasive principle is Doppler principle. Okay, the example for which is esophageal echo. So where you are using a Doppler ultrasound probe inserted into the distal esophagus, 35 to 40 centimeters from the incisors at T5 to T6 level, where you are directing the Doppler ultrasound probe to measure the blood flow in the descending aorta, where the ultrasound probe contains crystals producing continuous ultrasound wave, which could detect the flow in the descending aorta. And using the Doppler principle and the Doppler equation, it calculates the cardiac output, where it is equal to stroke volume into heart rate, where stroke volume is nothing but stroke distance into aortic root diameter. Okay, so heart rate into cross section of the aorta with velocity time integral. That is how it calculates the cardiac output. So what are the measurements we are going to get out of transesophageal echo? The main thing is cardiac output, stroke volume into heart rate, where the stroke volume is nothing but stroke distance. And we also get minute distance. And contractility indicator will be the peak velocity, where there could be age-related normal ranges. Like if the patient is 20 years of age, then the value is between 90 to 120 centimeter per second. And if it is an elderly patient, then the value reduces to 30 to 60 centimeter per second. And there is also corrected flow time, which is a preload indicator. The normal value is between 0.33 to 0.36 seconds, which indicates a preload status. And afterload assessment is mainly by the combination of the corrected flow time as well as the peak velocity. So what are the limitations? Of course, you need an expert who could do the esophageal echo. It depends on the accurate probe positioning. Difference in the flow measurement can occur with aortic coarctation, aortic aneurysm, and IABP. And it could be affected by the changes in the pulse pressure, vascular compliance, volume status, inotropes. And the probe can also detect other vessels like intracardiac and intrapulmonary vessel. The main contraindications are esophageal varices, esophageal stricture or tumor, or esophageal surgery. And complications could be esophageal perforation, may require sedation, and interference from the other surgical instruments like diathermy. Coming on to non-invasive methods. So the common non-invasive methods are bioimpedance, bioreactance, NICO are the common non-invasive methods. So we'll discuss about bioimpedance, where 6 electrodes are placed, 2 on the each side of the neck and 4 on the lower thorax, where it measures the resistance to the electrical current. And the bioimpedance is inversely proportional to the thoracic fluid content. So the main limitations of bioimpedance are electrocautery interference, inappropriate electrode positioning, obesity, pleural effusion, arrhythmias, and sternal wires could be the major limitations for bioimpedance. Coming on to bioreactance, where it analyzes the phase shift of the electrical voltage signal, where changes in the electrical capacitive and inductive properties from the intrathoracic volume changes. It is more accurate than the traditional bioimpedance. So it is easy to use and it can be useful in arrhythmic patients, and it is applicable in ER, ICU, and OR. So if you see the difference between impedance and reactance, impedance measures the changes in the electrical resistance. It analyzes the transthoracic voltage and amplitude change. But bioreactance, it measures the phase shift of the oscillating current voltage when traversing through the thoracic cavity. So when you compare impedance with reactance, reactance is higher signal to noise ratio, less susceptible to noise, better correlation with reference methods, and independent of electrode distance. So bioreactance is better for a cardiac output monitoring as per the studies compared to the bioimpedance, because there is a higher signal to noise ratio. It can be used even in patients who have arrhythmia. It can be used in a noisy environment in all possible, like ICU, ER, OT, wherever we can use it. And bioreactance is better compared to bioimpedance as per the studies also. So coming on to the next non-invasive method, which is the partial carbon dioxide rebreathing method, NICO. I have not seen it. I only read it through theory. So the main concept here is we are using a modified fixed principle where you are using a carbon dioxide for measurement. Like in pulmonary artery catheter, we are using the oxygen. Here we are using a carbon dioxide. And so you are selecting a baseline value where for the formula you need VCO2, how much carbon dioxide is produced, and the arterial concentration of the carbon dioxide, venous concentration of the carbon dioxide. So when you see in a normal patient before rebreathing, the EtCO2 corresponds to the VCO2. Okay, and arterial can be taken from the ABG, and from a mixed venous mixed venous blood sample, you can take the venous carbon dioxide content. This is in a normal patient. But when you make the patient rebreathe, okay, so you are basically making a patient to rebreathe more carbon dioxide than normal. So in a patient with a normal cardiac output, ideally the carbon dioxide elimination will be better. So the overall EtCO2 value will be like low. Like if you see in a good cardiac output patient, because the EtCO2 is proportional to the pulmonary blood flow, with good cardiac output, the carbon dioxide elimination will be more efficient and the EtCO2 value remains stable. But suppose in a patient with a low cardiac output, the carbon dioxide elimination will not be too efficient. So there will be it causes EtCO2 to fall at the baseline and rise excessively during the rebreathing. Okay, so if the EtCO2 is high during rebreathing phase, that means cardiac output is low. If the EtCO2 remains stable or a low value, that means cardiac output is good. That's all. So the main limitations are, of course, it requires mechanical ventilation. It can be inaccurate in severe chest trauma when the patient is having a shunt, and when a patient is having high cardiac output states or low minute ventilation states. So there are some limitations, but it uses modified fixed principles. Instead of oxygen, we are using carbon dioxide. That's all. So this is a picture showing the NICO, where you are measuring the baseline value, VCO2, EtCO2. And when you are making the patient rebreathe, the EtCO2 value goes high. So if the cardiac output is good, then the EtCO2 value will be low. If the cardiac output is poor, then the EtCO2 value will remain high. That is the concept. So the next non-invasive method is the transthoracic echo, which could be definitely asked in the Viva, because it is bedside and all we have to do is calculate few values and you can get the cardiac output. So where you are using a formula called cardiac output is equal to stroke volume into heart rate, where stroke volume is equal to velocity time integral into LVOT area. So how are we going to calculate the LVOT area? In the parasternal long axis view, you are going to measure the LVOT diameter in centimeter using area of circle formula. Okay. And again, you're going to calculate the velocity time integral using the 5-chamber view, where you can see the aortic valve also, where you are going to place the marker here and press the pulse wave Doppler, and immediately you will get a waveform like this, and you trace around the ejection wave to get the velocity time integral. So you have got the LVOT area, you have got the velocity time integral, so by which you can get the stroke volume, and you multiply it with the heart rate, then you will get the cardiac output. So the main limitations could be a proper image image quality is needed for this, because if you can't get the 5-chamber view and the aortic valve view, then it is very difficult. So in obesity patients, in COPD patients, and patients who are on high PEEP mechanical ventilator, there could be a difficulty in acquiring the images, and it is user dependent, and intermittent measurements are required. It is not a continuous monitoring. These are some of the limitations, but it is one of the good cardiac output monitoring, non-invasive bedside, which can be asked in the OSCE. Then comes another device called ECOM, that is endotracheal cardiac output monitoring. So basically, in the endotracheal tube body as well as in the cuff, there are some electrodes which could sense the impedance changes in the aortic blood flow. And using an algorithm, they calculate the stroke volume and the cardiac output, where it is a specialized, the main limitations could be we need the specialized ECOM ET tube with electrodes, and patient mandatorily requires intubation, could be some of the limitations for ECOM. And then comes photoelectric plethysmography, where it detects the pulsatile blood volume changes using light absorption and forms the basis of pulse oximetry and non-invasive hemodynamic monitoring, where it estimates the cardiac output by analyzing the pulse amplitude to derive stroke volume, which is multiplied by the heart rate to obtain the cardiac output. And the technique used here is called volume clamp technique. So there will be a flexible finger cup with light source which is tied around the finger, and this maintains a constant blood flow by adjusting the cuff pressure to match the arterial pressure. And you get a pressure waveform analyzed by the pulse contour method for cardiac output monitoring. So the main limitations could be low cardiac output states, poor peripheral perfusion, arrhythmias, and finger size limitations. This is one of the non-invasive technique. Then comes the final non-invasive technique, which is called pulse wave transit time, where basically it is nothing but the time taken for the arterial pulse wave to travel from the heart to the peripheral site. So it is nothing but an ECG to plethysmography delay and reflects the arterial stiffness and blood pressure. Higher BP shortens the PWTT, and lower BP prolongs it. It is basically an afterload monitor, not a flow monitor. Once you get the values in 3 phases, you use a formula to calculate the cardiac output. So it basically estimates the arterial tone and blood pressure, which when combined with the pulse amplitude and the heart rate gives us the stroke volume and the cardiac output. So the time taken from the ECG R wave peak to pulse wave rise point, where it is divided into 3 intervals, where we need 3 values for the calculation of the cardiac output: the pre-ejection period, the elastic artery period, and the peripheral artery phase, where the pre-ejection period is the ECG R wave to the aortic root pressure rise, and the T1 is the aortic root to the radial artery, and T2 is the radial artery to the SpO2 pulse oximetry wave. So 3 values we are deriving, and we are putting it in a formula to derive the cardiac output. Basically, it's an afterload monitor which gives us the cardiac output. The main limitations could be arrhythmias, poor pulse oximetry signal, and requires an ECG pulse oximetry continuously. So these are some of the non-invasive devices which is used for cardiac output monitoring. So when it comes to OSCE, the main thing you have to know is how do you classify the cardiac output monitoring devices based on principle and invasiveness and calibration. And number 2, when you take a device, you should tell what type of device is it, which mechanism it uses to detect the cardiac output, and what are the main limitations and contraindications. And these will be the common questions. I don't believe this NICO PWTT will be asked at all. Just revise and go. And mainly know the pulse contour analysis based devices, mainly the LITCO, PICO, volume view. And know about the values which comes out of the cardiac output monitor, like EVLW, PVPI. How could you differentiate between hydrostatic and ARDS? All those could be the common questions when it comes to OSCE with cardiac output monitoring devices. Okay. So the next class will be Dr. Darshan's. I guess sir is here. Let me check.
Hi, everyone. Yes,
Hi,
I joined in. There's a question on perfusion index, I think so.
Okay, sir. I'll respond to it, sir. You carry on
Yes.
and I'll respond.
Oh,
Yes.
okay, great.
Yes.
Is my screen visible?
Yes, sir.
Okay.
Yes, sir. It is visible.
Okay, thank you. So, good evening, everyone. I think so. It's been good 2.5 days already with your practical sessions, and you have been guided towards what to prepare for. So, thanks for tuning in and answering. I've just heard a lot of you giving answers. So, please continue the same trend as well. Uh, the next couple of stimulation stations will be on your data interpretation. Okay, and I'll also be dealing with your drugs today. Based on the time availability, I will see if I can complete even the AMST, that is your antimicrobial susceptibilities testing. Okay, if not possible, I'll reschedule for another class. Okay, but the only thing is, I want you guys to interact as much as possible and take your time. Okay, because drugs, I have a lot to complete, so I will try and do as much as possible. It's practically impossible to do all the drugs. We'll try and at least go through a systematic approach, and then we'll make it quite interactive. Okay, so without wasting much time, I'll go directly into the first topic of the day, that is your data interpretation on viscoelastic testing. So this is something that I've already dealt with in the theory chapters as well. So the basic thing is, you need to understand what is the working principle, where do we use it, okay, and few examples, and then we'll summarize, okay, and what practical questions can be asked when they are giving you a data interpretation based on a viscoelastic test. You all know coagulation cascade. The older way of remembering was the extrinsic pathway, intrinsic pathway, and common pathway. So extrinsic pathway, you have the PT for the assessment. For the intrinsic pathway, you have the APTT, and for the common pathway, you have the TD, or the thrombin time. Okay, so this was the earlier understanding, and you used to send all of these tests, right? Your PT and a basic coagulation pathway along with your bleeding time and clotting time. Okay, so these are the things that we were focusing earlier on with your complete hemogram and probable fibrinogen if you are also working up for possible DIC. But then we also came into understanding about the new way of understanding how a clot forms, that is your cascade mechanism, wherein it starts with an initiation of a clot followed by amplification phase, propagation phase, and a stabilization phase. Okay, it is still fluidic. We cannot just tell that this is segregated into just extrinsic, intrinsic, or common pathway, but all that needs to be understood is how a clot forms, how it is stabilized, and how it gets lysed. Okay, so this is the basic understanding which helped us understand or formulate viscoelastic testing. Okay, so by and large, whenever we have to do this, you will do a PTINR, platelet, and test for any fibrin degradation products like D-dimer. Correct? This is time again you'll do. So what are the drawbacks? Can one of you unmute and answer this? So what are the drawbacks or limitation of using the classical method of sending in for labs like this in a patient who is bleeding? Say, suppose you have a patient with trauma who has come to you and you're sending all of this test. Can anyone unmute and answer?
We are not getting to know the functional pathway.
Excellent. Okay, functional assay. Okay. So is viscoelastic testing going to help you about functionality of any of those products? Like functionality, when we talk about majorly platelets. Will it help you understand that? One good thing here also, it will not tell functionality. Okay, good. Answer is correct. Okay, but if you're comparing with VEA, again, there also it doesn't. One is good. Other one, the answer is correct. Whatever you said is correct. Okay. Usually this takes a longer time, no? Roughly minimum 2 hours and above. Okay, so that is one of the major drawbacks for this. Okay, and then there's a lot of other things that is going to happen also. So how do we send samples for all of this? Can you just whoever is answering, can you please introduce yourself and tell what is the vacutainer that you send, what is the volume required, okay, for each of them, so that you'll understand even the drawbacks there. Okay, go ahead. For APTT and PTINR, what do you send?
With the citrate anticoagulation.
Okay, what is the tube?
Volume should be 2.5 to 3 ml minimum. Should be.
Okay, what do you use? The color coded? Usually it will be different, but
blue
yeah,
coded.
okay, blue is, at least for this, it's very universal. For platelet count?
Purple to VDTA tube.
VDTA tube, okay. And fibrinogen? Okay.
The blue color
Please,
tube.
Okay, blue crop. Okay, it's the same thing. Okay, the thing is, you need to remember what you do at bedside. So usually, if you examiners are interested in knowing what do you send the sample for. Okay, so the basic thing is you need to remember what is the volume which has to be sent and what is the type of container that you send. What is there any drawback of sending sample, like if a platelet count comes low and the sample has been EDTA, do you still consider that has to be a false negative?
So we need to
Sometimes.
rule out pseudothrombocytopenia.
So what would you do at that time?
Sir, we will ask the pathologist to review whether there are any platelet clumps, and
Okay.
we will send a repeat sample in either citrate or heparin bulb.
Okay, good. So usually you send a citrate sample and then good, you have to ask for a smear reporting whether there is abnormal clumping. Okay. So this happens usually if you have a patient's platelet count being normal and suddenly there is a drop which is not explained by any other reason. Okay. So that is one drawback with EDTA, which you can see. Mostly we see in non-critical ill patients, but critical ill patients also, if you feel that it is not correlating, please remember one of the drawbacks. Okay. So coming to the class per se, viscoelastic testing, it's just a global test for coagulation. It's usually performed in the whole blood. Okay. So if you're with me till now, you know the samples required earlier here is roughly around 3 ml, right? An average is 3 ml, which we are taking. So how much volume would be taken here in viscoelastic testing? Any idea?
They take 2 to 3 ml, sir, in plain
0.3
tube.
ml.
Sorry? 2 to
They
3
take in
ml is
plain
for the
tube.
regular testing. For viscoelastic, the cup usually cannot take so much. It's very minute. I think so. Some other person told it.
0.3 ml, sir.
Yeah, 0.3 ml. Okay, it's a very minute thing. Okay, so it's very minimal sample. That is one of the advantages of viscoelastic assay as compared to the regular coagulation parameters. Okay, just remember it allows both quantitative and qualitative measurements of all the components which are involved in formation of a clot. That is your coagulation factors, your platelet, and your fibrin. Okay, so all these things are what is tested and studied in viscoelastic assay. Okay, and most importantly, lysis of the clot is also, which is something that we can study with the viscoelastic assay, which is usually not being understood by your routine PTA PTT INR. Okay, so that is one of the other advantages of viscoelastic assay compared to your regular PTA INR. Most importantly, why this came into picture is a point of care device where the turnaround time is less than 1 hour. Okay, it depends on the type of viscoelastic assay. So, what are the types of viscoelastic assay you guys know?
The tag and rotate.
Thromboelastic gram and like rotem.
Okay, so what is the thing that it does? What are the things that it majorly looks at?
Initially, clot strength, clot formation,
Very good, good.
then fibrinolysis.
Breakdown. Excellent. Okay. So you answered it in the right way also. So usually formation, remember it's a process, right? So there is an injury. Then with the injury, you have to get the clot formation first. And then after the clot forms, it has to get some strength. And then there is breakdown, which usually the breakdown should not happen quickly, right? That is what usually it is seen in the viscoelastic testing, be it TEG or ROTEM. So what is the working principle here? For TEG, what is the working principle? What is the working principle for ROTEM? See, your questions are going to be simple like this, okay? I cannot make it another theory class. That's the reason I'm asking you questions. So it's electromechanical transduction for TEG and optical detection for ROTEM, okay? So you'll understand that. So in TEG, what is the mobile part, and ROTEM, what is the mobile part?
Sir, in tag is the caveat or the cube is the rotating part, while in the
Up
rotate,
is the
the
good.
pin or torsion wire is rotating.
Very good. Okay. So that is what you need to understand. Basics. That's all. Nothing more than this. If you remember, it's more than enough. Okay. Remember, the cup is rotating in TEG, and in ROTEM, it's the pin. And because the pin is rotating, that's why there is an incident light on the pin, which reflects and sends it to the data processing unit. So that is why it is a rotational thromboelastogram. Okay, so usually already you had TEG, right? That itself was good enough. Why did they want ROTEM? Any idea? Anyone can answer this question? Is ROTEM going to give us something extra what TEG is not going to give?
So
So
TEG
that's
can cause the mechanical stress.
excellent. Okay. So in TEG, there is continuously rotating shear stress which happens. Okay. So that also they wanted to remove, and that is one of the main ideas for ROTEM. But majorly there is no difference. Okay. That was the idea behind getting for ROTEM. But it's not like TEG is inferior and ROTEM is superior. Okay. That is not the take home I want you to take. Both are equally good. Okay. You can use either one of them. Okay. So this is how you usually have a graph which will be given to you. Okay, so this might be a typical normal viscoelastic graph. Okay, so usually you'll have a lot of nomenclatures that you need to remember. Okay, so you have time in the x-axis and amplitude on the y-axis. So the first half of the graph is called the thrombogenetic pathway, and then you have the fibrinolytic pathway. Okay, so whatever is in purple here is the ROTEM parameters, and whatever is in green is in the TEG parameters. Okay, so initially when the tissue injury happens and the clot forms and all your clotting factors come into picture, usually it helps us understand the arc time or the reaction time in TEG, or its clotting time or in ROTEM. Okay, and then you have fibrinogen coming into picture, that usually is measured by the alpha angle. Okay, and then you have the K or the clot formation time in ROTEM. Then you have the maximum amplitude or maximum clot firmness. This is about the platelets. Okay, and then you have lysis. Okay, this is usually your activity of plasmin. Okay, so whether there is early breakdown of the clot or not. So this is by and large about the availability of clotting factors, the strength of the clot, which is beginning here, and then availability of platelets, and then breakdown of the clot. Okay, this is roughly how you have to look when any viscoelastic graph is given to you. Okay, so we'll go to thromboelastogram per se. Okay, I told you earlier, R time stands for reaction time. Okay, or usually it is the time to first deviation from baseline. Okay, it starts from here and then it ends here. So if this is the end point of our time. Okay, so it usually helps us understand whether there is some deficiency in clotting factors. Okay, so usually it starts at the time of vessel injury and at the beginning of some amount of mature clot being formed. Okay, so sorry, immature clot being formed. Next you have the K time. Okay, K time is usually deviation from the baseline till there is some amplitude, a roughly pre-specified amplitude, usually 20 mm amplitude is what we take into consideration. Okay, so this is usually going to help us understand whether there is fibrinogen acting at the right time and whether there is polymerization of fibrinogen also happening. Okay, so after this you have something called as the alpha angle. So what is alpha angle? Alpha angle is nothing but the angle between the baseline and the tangent, okay, that intersects the initial deviation. So if this is the initial deviation, so you have to have a line which is here, and this is the tangent drawn to the initial deviation. So this usually helps us understand the alpha angle. Okay, so both K time and alpha angle will give us an understanding about fibrinogen issues in the clot. Okay, so R time, your clotting factors, K and alpha is for your fibrinogen. Maximum amplitude is the maximum deviation from the baseline is called as the maximum amplitude, and this usually represents the amount of platelet which is being present. Okay, so usually this has to be taken in consideration with the alpha angle also. Okay, so now we are commenting about maximum amplitude. First look at the alpha angle and then talk about maximum amplitude. Sometimes if the alpha angle is acute, okay, so probably it is fibrinogen deficiency. That is the reason it is causing a drop in the amplitude. Okay, probably the platelets are normal at that point in time. So you have to always look whenever there is, if you feel that the maximum amplitude is shortened by any sense, then you have to look at alpha angle as well. First comment on the fibrinogen and then talk about platelets. Okay, so if you are till here, we have started with the vessel injury, clotting factors, fibrinogen, and platelets. So we started with an injury, immature clot, and mature clot, where the fibrin stands and platelet plug has already happened. Next part of the thing is the lysis part. So this plug, when it forms and blocks the bleeder, it should continue there. The thing in trauma elastogram, that advantage over PTIN or what we send is to understand if this clot is breaking down prematurely because of activation of plasmin. Okay, if the plasmin comes and acts there and it breaks down prematurely. So that is what we see. So that is in TEG called as lysis 30. So usually it should not break down before 30 minutes. Lysis 30 means 30, the number stands for the timing from there. Okay, if the amplitude drops more than 15% in 30 minutes, that means to say there is premature lysis. Okay, so it's 15% of drop. So usually you'll have something like a top which comes down. Okay, so suddenly the amplitude is here and then it drops earlier. Okay, so 30 minutes timeline would be provided. As you know, in earlier slide also I showed you there's a timeline in the x-axis. So if you feel that it has dropped earlier and that percentage of drop is more than 15%, so that means to say there is premature lysis. Okay, so this is by and large about how we look into thromboelastogram. Okay, so R time, clotting factors, K time and alpha, fibrin, maximum amplitude, usually it is fibrin first and then the platelets and then your lysis part that you see with plasmin. So this, I think so, will give you a fair understanding of how to approach a case with TEG. Okay, so let us go to questions now. So you have a patient in the trauma bay with TEG R time showing 15 minutes. The normal range has been given as 5 to 10 minutes and the maximum amplitude is normal. What is the most appropriate intervention that you want to do? R time is what?
Clotting factors.
Or FFP.
So what do you want to do? Give transfusion of cryo, FFP, Tranexa, platelets.
FFP we have to.
FFP. So why do you guys don't want any cryo? Why do you guys don't want Tranexa? Why do you guys don't want platelets here?
Because the most of the clotting factors are present in FFP, sir. So
Really? Oh, okay. So don't, okay. That cannot be the only answer. See, first you answered correctly by telling it's FFP, okay? But you will look at this question. The maximum amplitude is normal, correct? So if you tell maximum amplitude is normal, what did I tell you? Two things. Fibrinogen is okay.
platelets function.
Platelets also is okay.
Functions are normal.
Okay. And there is no issue with breakdown thing that they have mentioned here. So no need of tranexamic acid, correct? So by that method, we will say that it is that. So usually it doesn't, someone told that, it is more in FFP, it's not like that. So you have to know what is the amount of fibrinogen in FFP, what is the amount of fibrinogen in cryoprecipitate, what is the amount of clotting factors in FFP, what is the amount of clotting factors in cryoprecipitate. All of that questions will be asked to you, okay? So when you're answering, do a rational way, okay? Otherwise, you'll be taken to those. I will be asking about this in the end of the class, but definitely you have to know that, okay? So that is how you go there, okay?
So just one more doubt. If the maximum amplitude is normal, does it mean the K time should be also normal?
So yeah, that's why whenever the maximum amplitude is normal, you look at the K time also. Definitely it has to be normal. If the fibrinogen is normal, sometimes what will happen, maximum amplitude will be normal because platelets are normal, but the alpha angle will come down. Okay. At that time, you see what is happening with that K time also. If the K time is prolonged, that means to say that will have some fibrinogen deficiency as well. So K time, alpha angle, will tell you about your fibrinogen, and then MA at that time, if you feel it has dropped a little, probably it is because of fibrinogen. Understood?
Okay.
Okay. So fibrinogen, whenever you have the doubt, you will have some changes with the K also. Okay. So what is the parameter on TEG tracing primarily which does contributes to fibrinogen?
The alpha angle.
Alpha angle. Okay. Good. Wine bottle shape of TEG tracing, where the maximum amplitude is reached, but the curve narrows significantly within 30 minutes. If you have heard me till now, you should answer
Primary
this.
hyperfibrinolysis.
Good. Okay. So it is hyperfibrinolysis. So they're not going to ask you some very rare disorder. They're going to stick with very simple ones. Okay. So if you answer these, I think so you're pretty good with your TEG. Okay. So remember, this is how it looks like. R, K, maximum amplitude, all of them are normal with the angle. This is how the TEG will look like. Okay. If you have any anticoagulation deficiency or hemophilic disorders, you'll have something like this. Okay. It's like a champagne glass. Okay. So here what happens, there's factor deficiency. That is the reason your R and K time both are prolonged. Okay. So then you have maximum amplitude and angle also being decreased because of this. Okay. Primary platelet problems, usually you will have a decreased amplitude. hyperfibrinolysis, you will have like this, okay, a top like a turnip like image. Usually DIC, there are two stages, right? The bleeding type and the clotting type variants. Okay, so you will see in stage 1 a hypercoagulable state. In stage 2, you will see a hypocoagulable state. Okay, you will see a bleeding type later. First, you will see the clotting type. Okay, so this is basically about how you interpret TEG. So most of the centers with transplant setting will have this. Okay, so as a guide, as a take-home message, if you're taking for TEG, any increase in R time, FFP, decrease alpha angle, cryoprecipitate, the whole thing is about fibrinogen. Maximum amplitude, probably have to give platelets. Then you have to consider DDAVP. Can anyone tell me what is DDAVP?
Desmopressin.
Desmopressin. Where do you use it?
Functionality of the platelet is depleted.
Okay. Yeah,
When
somewhere.
patient is on aspirin or
Platelets, antiplatelet,
antiplatelet medications.
and gluculid.
Can you be
Or
a little
in
more
case of
specific?
uremia, azotemia patient, renal dysfunction with the
Yeah,
coagulopathy.
these are azotemia. All of the usually the von Willebrand factor and this platelet interactions would be not proper. For such cases, we use DDAVP. Usually, it is one of the last resorts we use. Okay, so you have to remember that part of it. So platelet functionality in combination with von Willebrand factor. Okay, so that is where we use. The release is what is the problem. Okay, it has to the platelet has to go form a plug, right? So that is the usual problem which will be happening because of these interactions. Okay, and fibrinolysis, you guys know the answer is giving tranexamic acid. Okay, so coming to the next half of the class on viscoelastic, that is your rotem. So I know most of you guys are well versed with which one, TEG or rotem. You guys use it?
TEG, sir.
TEG. Okay, so that's one of the usual problems because most of them feel that rotem is a little more complicated. TEG usually it gives you a complete graph at end of 30 to 40 minutes. Okay, but rotem keeps giving you bits and pieces. Like first 15 minutes one graph, next 15 minutes one graph. It's like that. Okay, so most of the reasons you have a lot of terminologies here in TEG, you just have the R time, K time, alpha angle, maximum amplitude, and lysis 30. That's it. And you can make the diagnosis. But ROTEM becomes a little more complicated because it has a lot of other terminologies like INTEM, XTEM, HEPTEM, FIPTEM, APTEM. Correct? So few centers who practice cardiac surgeries and liver transplant, they will have this graph. So it might be overwhelming. So I'll go in a systematic way. Okay. So you can listen if you've not understood or if not used this till now. Okay. Similar to what you see in tech, the same terminologies will be here also. Most of the times they usually have to give you a color coded image, but if they don't, it's still okay. But you can see that. Okay. Usually the R time, which was there earlier for TEG, is the CT or the clotting time in rotem. Okay. Then you have the K time or what is called as clot formation time in rotem. Alpha angle is similar to what we see in TEG. Okay, the same thing is here. Okay, it's the basic thing is at the beginning of the CFT or the ending of CT, wherever there is a tangent which is drawn to the baseline, that is the alpha angle, similar to what you see in TEG. Here, after this, they don't go just to maximum amplitude. Here, maximum clot firmness is synonymous to maximum amplitude in TEG. Okay, before that, they have something called as A10. Okay, so A10 is the amplitude at 10 minutes after CT. Okay, from here to here. This is the A10 value. Okay, then they have the lysis 30 here. Okay, so usually maximum lysis is the end of the rotem. Okay, so this is basically how the terminologies are for the graph of rotem. Okay, this is going to be there in all the things I mentioned earlier. I told you there are things like INTEM, XTEM, HEPTEM, APTEM. Okay, I'll tell you what those TEMs mean. Okay, so don't worry about it. So CT or clotting time is the time from starting to the measurement until the initiation of the clot is done. Okay. So here the clot polymerization would have begun. Okay. Then CFT, usually fibrin polymerization would have started. So again, similar to what you see in K time here, it's about your fibrinogen values. Okay. So usually it mixes with factor 13 and thrombocytes. Maximum clot firmness is the stabilization of the clot. Okay. And then lysis again gives you indication or an idea about what is happening with the clot, whether it is being stable or there is premature hyperfibrinolysis. Okay, so this is the first thing that you need to know. Similarly, you will have time in x-axis, and then you'll have the amplitude on y-axis. Okay, greater the amplitude usually tells that the clot is firmer. Okay, so whenever there is this CT, clotting time happening, no, so usually you will see the color in green. Okay, so anything it prolongs after that will come as pink. Okay, so that will be between 2 to 20 mm. Okay, so first 2 mm will just be green, and then it will become pink here. You see here, first you have the green here, and then when the amplitude becomes more, it will become pink. Okay, and then when the amplitude is more than 20 mm, the color turns to be blue. Okay, so this is why I told you earlier, they usually have to give you a color coded thing, because you can immediately pick up what is the problem. Any problem with green, okay, so usually it is the clotting factor problems. Any problem with pink, it is issues with fibrinogen. Any problem with blue, it's with your platelets or probably hyperfibrinolysis. Simple. If you can't remember anything, if you remember this much, I think so you can interpret rotem, at least by basic common sense. Okay, so green, if there is any changes with that, if it's too long, probably it is prolongation of CT. Probably the issue is with clotting factors. If pink is the issue, if there is just pink being there, there is no blue at all, probably there is issue with fibrinogen. Okay, if blue forms initially and then drops, two things might be problem. Firstly, if it's a small amplitude, that means to say there is less platelet. If it forms and then drops immediately, less than 15%, again that is hyperfibrinolysis. Okay, so this is about how a rotem graph looks, and this is the comparison with TEG as well. Any doubts till now? Have I made things a little easier or simpler, or do you feel it's still complicated? Okay, so if nothing is to be asked, so this is what you guys have to remember. Okay, so clotting time, usually it tells you about PT, APTT, and the clotting factors. Okay, so maximum clot firmness, initially fibrinogen, then about platelets. Lysis is lysis 30. That's quite simple. Okay, so similar to what we have in the classic pathway, right? Extrinsic pathway, intrinsic pathway, it's something to the same thing. The terminologies have been formed in rotem. So extem is nothing but your extrinsic pathway. Okay. So in extrinsic pathway, what do we do? APTT, right? So that is the thing that we want to mimic in this. Okay. So because we want to mimic something which is not happening there, you have to have a tissue factor which has to be introduced. So usually whenever there is a vessel injury, there's a tissue factor which is released. So that is the reason in extem what happens, they add a small amount of tissue factor. Okay, so usually the clot formation can be seen within 10 minutes. Okay, so this is the first basic assessment in rotem, whether the clot CT time is less than 10 minutes. Okay, so again 10 minutes is quite a long time, so it will see all the other parameters, it will continue. Okay, this is the one part of the rotem. Next is intent. So it will see the intrinsic pathway. Okay. So what will happen here is usually all the other clotting parameters like your factor 8, etc., will be looked into. Okay. So this is about your intent. So next we have the FIBTEM. As the name suggests itself, it is fibrinogen assessment in rotem. Okay. So what happens is, because in the earlier graphs, you see there is fibrinogen and suddenly platelets come into picture and it will mask the activity of your fibrinogen. So here there is an enzyme called as cytochalasin D. They add that so that the thrombocytes are blocked. And after you block this, it will only give you the assessment of fibrin formation and fibrin polymerization. So if some question has to be answered about fibrinogen issues, then it will be FIBTEM that you have to look into. Okay. So last thing is your hyperfibrinolysis. There you look into APTEM. Okay. So if you're with me till now, usually what you have to do is you have to look into the extem first and then aptem. Okay. So what happens in extem is the first there will be a formation of clot here. Okay. And after the formation of clot, you see hyperfibrinolysis. So in aptem, what they do is they add tranexamic acid or they add something called as aprotinin. Okay. It is going to inhibit the fibrinolysis, and it will cause normalization of clot function. So if this abnormality in extem is corrected in aptem, that means to say there was hyperfibrinolysis. So it's like a check and balance. Okay. So you know the problem, you give the treatment and see if that treatment is helping the clot formation get back to normal. Okay. So this is the check and balance for hyperfibrinolysis. So you compare it with the extem. Okay. So we talked about extem, intem, extrinsic pathway, intrinsic pathway. Then we talked about FIPTEN, that is for fibrinogen analysis. Then we talked about APTEN or aprotenin pathway, wherein you see for hyperfibrinolysis correction. Okay. So whenever you're doing APTEN, remember first you have to look at extem and then interpret it with APTEN. Okay. Extem will show abnormality. If APTEN is getting it corrected, then it is the issue with hyperfibrinolysis, which has been corrected by addition of tranexamic acid. Okay. Next, we have hepten. Okay. So you know a lot of major surgeries like cardiac surgeries or even transplants, etc., where then they might use heparin. Even the doses, all of this sometimes it goes amiss. And even though you have given protamine for reversal of heparin, you might not know, and the patient might be still bleeding. Okay? At that time, what you need to understand is first you look at intem. If intem is getting prolonged, as you can see in the first graph here, so what they do is they add some agent called as heparinase. Quite simple and straightforward. If you add heparinase, it will lyse the heparin. If the CT turns back to be normal, then it is the effect of heparin. Okay. So to understand if heparin is causing bleeding, especially in a perioperative setting or an intraoperative setting, you use hepten. Okay. So these are the advantages as compared to TEG. TEG, you don't have anything related to primarily looking at fibrinogen, primarily looking at heparin, etc. Correct. So these things can be offset with the use of roten. Okay. So TEG also there is called as heparinase TEG right now. Earlier TEG didn't have this, but the latest TEG they have heparinase TEG. Okay. So again, you have to give heparinase there and then check the TEG. It will help you know. So it's not like it was not available at all in TEG. Even in TEG you can incorporate heparinase. Okay. So basically these are the things that you need to go ahead, start looking at the extent, look at whether there is any issues, then look at the intrinsic pathway with intem, fibrinogen issues with FIPTEN, APTEN, see extem first. If there's hyperfibrinolysis, if it's getting corrected in APTEN, that means to say you have to give tranexamic acid to the patient. If the patient is a post-operative patient or the patient is on heparin for some reason and there is bleeding and the CT or the clotting time, the green line is prolonged, then probably it is hepten which is causing it. So if you can give heparinase and the CT turns back to be normal, it is the issue with heparin. Okay. So there's a lot of values which is there. Okay, it will be given in all the graphs here in below. So you need not mug up, but then you need to know if it is following in the cutoffs which has been given. Okay, so roughly if you can remember this values, especially for intem extem, that's more than enough. Aptem, it's okay. FIPTEN, remember one value 40. Okay, if you see here FIPTEN, we are not giving anything regarding CT, CFT or lysis 30 or maximum lysis. The only thing we are talking about is alpha angle and maximum clot formation and A10. So why we do this is, remember if FIPTEM value is less than 40, okay, that means to say it is suboptimal. So if you can remember this one number also in all of this, I'll be happy. Okay. So any value of FIPTEM less than 40 indicate, especially in the alpha angle, you have to take it as a probable issue with fibrinogen. Okay. So probably it is a DIC. Okay. So you start with extem, intem, heptem, FIPTEM, and aptem. Okay. So this is how a normal trace would look like. Okay. So I told you earlier, this is how you have to go about. Okay. So in the first graph, you see there is a stable clot. Here you see hyperfibrinolysis. And here probably the maximum amplitude has not reached the normalcy. So probably there is issue with the amount of platelet which is present. So the clot is probably weak or fragile. Okay. So here I told you intem CT is prolonged. They added heparin, it got corrected. Okay. So usually, okay. So if the CT is very high and it gets corrected with the addition of heparinase, that means to say it is heparin induced bleeding disorder. Okay. So again, you see the FIPTEM here. Okay. So you see earlier there is in XTEM, I told you the maximum amplitude is not up to the mark. Okay. So firstly, you'll have two doubts here, similar to what we had in TEG, whether platelets were normal or fibrinogen was the issue. Correct? To answer whether fibrinogen is the culprit or the platelets, then we have to do a FIPTEM. Okay. So if you feel that the FIPTEM, okay, value is normal, then probably the issue is with the platelets. If the FIPTEM itself is low, that is, I told you 40% or 4 mm at 810, then probably it is reduced, and probably these patients will benefit with the use of cryoprecipitate. Okay. So let us go to examples so that you will understand. Okay. So can anyone comment on this? If you have understood this, you can tell it clearly. What is the green line? What is pink and blue here?
The green line is plotting time.
Is it normal? It's 200.
Looking short also.
Okay, amplitude is normal. You have this dotted green lines, right? It's above that. Okay, this is quite short. Okay,
Hypercoagulable.
It seems normal rotation.
excellent. It is normal. Okay, so usually what happens in an exam, you'll be looking for some abnormality, and most of the time it is normal. Okay, so here you see, okay, someone was telling about hypercoagulability. If you see hypercoagulability, then you have to see that these parameters also will go up. Okay, so unlike anything here, all the other parameters are within normal range. Your extrinsic pathway, your intrinsic pathway, both are within normal limits. Okay, if you see the green line is here and the pink line also started happening at the right time, and it has been remaining normal even in aptem and fiptem. Fiptem, I told you, remember the number 40% of 4 mm at 810. Okay, it's 9 mm. So that is also quite normal. Okay, anything more than 12 or something, probably think of hypercoagulability. Okay, good. Any doubts here? Still worried? Still didn't understand?
Sir, can you repeat how the rotem can indicate hypercoagulability?
So hypercoagulability, usually you have to see if this CT is shortened, okay, one, and the amplitude is larger, and then FIPTEM fibrinogen values and platelet also will be higher. So usually you will see a little widened graph. So you cannot, earlier and I showed you 1 minute. Okay. Okay. If you see this stage 1 DIC, right? So this is one thing that we see this graph. It's something, this is how it will look like, the image. You see it's quite short here and then breaks down and then comes back. Okay. So this is how the graph would look like for a hypercoagulable state. Okay. Okay. Can anyone answer this? It's very simple.
Heparin effects.
Excellent.
Sir,
Why do
heparin
you say
effect.
that? Why do you say that?
Sir, the CT is very long in the in-time while it's normalized in the head-time.
Excellent. Okay, so I think so. You understood how to go approach rotem now. Okay, so you saw extem is normal, okay, or near normal, and then you saw intem is quite prolonged. Okay, so after that you saw what happened to heptem. Heptem it became normal. So that is an indication of use of heparinase. Okay, so good. Next question.
Hyperfibrinolysis.
Good. Why do you say it's hyperfibrinolysis? Only hyperfibrinolysis?
Sir, heptame is normal while is the extime in the in-time is the Li is quite high.
What happened to the pink part?
Yeah, it's I think hypofibrinogenemia also.
Okay. So what do you think this is? Okay, it's a combined hemostasis disorder.
Combined image.
There's a lot of problems here. Okay, so to break it down, starkly, like if you see the first thing, you can tell that definitely there is hyperfibrinolysis. Correct? Your CT is prolonged. Okay, then your aptem, it's trying to correct, but then it is not correcting fully. Okay, so that means to say that there is some issue even with the numbers there. Okay, so here you saw extem and then you saw your aptem, correct? So here there's hyperfibrinolysis, which is being corrected with tranexamic acid. Okay. So, but then you see it's not reaching the green lines here, which is an indicator of normal function. So that will give you an idea that there is some issue with what?
Fibrinogen also.
Platelets. Platelets.
Okay.
Platelet. Amplitude is always platelets. Okay. Then again, you see in FIPTEM, do you see anything here with the color pink?
No.
So what does that mean?
Low fibrinogen content.
Okay, so that is one more. That's why I told you earlier, remember the colors, that will be easier. But again, if you see here, you have to see A10, nothing is given.
Yes.
Okay, so is it clear with everyone? If anyone has doubts, I'll tell you. You can go it in a systematic way. Okay, so firstly, you look at the extem. Extem itself is showing a very fragile clot. When I say fragile, you can see the amplitude is not reaching up to the mark. Immediately, there is hyperfibrinolysis. Okay, so that itself is seen, and this got corrected by the use of aprotenin or tranexamic acid. And after giving that, it is fairly getting back to normal. But again, the amount is not enough. So when the amplitude is not coming back to normal, you have to look for issues like what is happening with numbers. First, start with your coagulation factors. So if you start
So
with
we
your
have to give
coagulation
the
factors,
so we
sorry,
have to give the Trenexa and the cryo and platelet all.
everything. Okay, so that's why we'll go step by step here. Okay,
Mm.
so you firstly you have a fragile clot, okay, which is seen in the extem. Okay, but because you guys told it's hyperfibrinolysis, the first step itself, it's getting corrected here, so definitely that is there. But then in intem, I told you intem will tell about what? Your R time and TEG.
Intrinsic factors. So basically.
So clotting factors.
Ah.
So there is a deficiency of that as well. Here CT is 670. So anything more than 200, you take it as prolonged to 200 to 250. Okay. So this is quite a long line, correct? So there's a clotting factor deficiency. Then you look at fibrinogen. Fibrinogen, you can't see anything at all. It's almost zero. Okay. So again, that is also deficient. Okay. So that is the reason we call it as a combined hemostatic disorder. You have problem with clot initiation, clot formation, clot stabilization, clot lysis. All the four parameters are deranged here. Any doubts? Okay. So what all you have to give here?
FFP or cryo and this
So
tranexamic acid as well as platelets.
okay, good. Okay. So usually this is what I want you to take in. Okay. So it's a zero line. There is nothing in FIPTEM. Okay. So fibrinogen is what we want. So which blood product has a higher concentration of fibrinogen, whether it is cryoprecipitated or FFP?
Cryoprecipitate.
Hypnogen.
Cryoprecipitates.
Okay.
Cryoprecipitate.
So how do we give it and how do we test? So the questions from here, no, whenever you get TEG or ROTEM, questions will be asked on what is massive transfusion protocol. Okay, so what are the individual blood components and how much they will increase your values by. Okay, all of that will have to be answered. So coming to
Usually for fibrinogen, one bag of cryo is given for every 10 kg. For example, if a person is 60 kg, so we give him 6 units of cryo.
Very good, very good. So that is what I wanted. Okay, I was coming to those questions. Excellent. That's how I wanted guys to answer in exam as well. Okay. So what are the drawbacks of your viscoelastic testing? Earlier, someone told about platelet functions. Can it tell function? Functionality of platelets can we test with viscoelastic testing? Patient is on all of this aspirin.
No, sir.
Okay. What do you use for that?
Uh,
Sonoclot, platelet aggregometry. Okay, all of those tests have to be done. Not required, but I'm just, if they ask you, okay, that is one of the drawbacks. Secondly, what other thing is the problem with Rotem? What is the this thing? Uh, Usually, what does it consider and then do the assessment as?
Actually, the clotting factor should be there. If the R type starts only, it can proceed for the further. If there's initially the clotting factors are very much depletional, then the graph won't even start.
That's okay. No, that's already that's the function of TEG. But what does it skip? What is one vital step in the body in vivo condition which is skipped
Ca-
here in this?
Temperature.
Calcium also it does not measure.
Excellent. Both of you, both the answers are correct. Okay. One of you told temperature, one of you told calcium. Okay. Both are things which are taken into consideration as being normal here. Okay. So it does it at 37 degrees Celsius and it will not account for any issues with calcium. So if you have corrected all of these parameters and your patient is still bleeding, probably think of these two as the reasons. Okay. So even then, if it is bleeding, probably you need to think about what else. Your von Willebrand factor deficiency, and that's where your DDAVP comes into picture. If you guys see, usually CABG, whoever is there in cardiac centers, they'll have an algorithm for a massive bleeder like this. Okay, so they go in stepwise approach. Okay, after PCC, everything is given. Still, patient is bleeding. Okay, DDAVP, everything will be given. Ultimate thing, what they look at is before giving PCC, they look at ionized calcium levels. Okay, and before that, they look at temperature. All of this have to go in a stepwise manner. Okay, so remember, Rotem does not account for temperature. Rotem does not account for von Willebrand factor. Rotem does not account for calcium. Okay, because all of these are very important for clotting cascade. Okay, so remember this is the take home message. If it's TEG for our time was a summarization. Okay, you just have to answer me. I'll ask you questions. In TEG, what does our time tell you? If our time is prolonged, what does it mean?
Clotting factors, depletion of the clotting factors, R time is prolonged.
Excellent. Okay, so I've given you the answer, the slide. You can see the slide and answer. Okay, if the maximum amplitude is low, what will you think about? How will you approach?
So first we
Platelet
have to see the
efficiency,
K and alpha angle.
Excellent.
And
Okay,
after
please
that we
look
have
at
to see
K and alpha angle. And then if you K and alpha angle are alpha angle is acute, K is prolonged, probably it is fibrinogen. After that, you also look for platelet count. Both you have to look. Okay, it is not just platelets. Good. Okay, lysis 30. If it happens less, if the clot breaks down before 30 minutes, what is the indication? It is hyperfibrinolysis. Treatment is tranexamic acid. Okay. Similar what we see in Rotem. If you guys can remember, extem is extrinsic pathway, intem is intrinsic pathway. Okay, and then we have fiptem, aptem, heptem. Okay, basically you have to remember your extem and intem, and then you have to use those for the other three parameters. So if you have issues with hyperfibrinolysis, okay, so what will you see first? What will you see? Hyperfibrinolysis.
Sir, maximum lysis, ml.
Heptam, sir.
Extem. Okay.
Yes.
So first you have to see the extem, and then you have to go to your aptem. Okay. So if you can remember this slide, it is good enough. Okay. So whenever you have extrinsic pathway issues, look at extem. Intrinsic pathway issues, intem. Intem, if there is any abnormality, like your green line is too long, it is intem. Okay. So usually the issue is with your clotting factors. Okay. And if after these two things are problematic, you have to look at subsequent one. So if it's a post-operative patient with heparin, first what will you see? Heparin makes what is the abnormality you have when you give a heparin? If you do APTT, will be prolonged, right?
Intem, sir.
Okay, good. Intem you'll see first. After that, to see heparin's functionality, whether it is reversed, what will you do? Heptem, correct? So first do an intem. Then if you add heparinase to the intem, if it gets normalized, that is your heptem. Okay. So that will help you understand the effect of heparin. Okay. For every other thing, be it FIPTEM or APTEM, you have to first see the EXTEM and then see whether FIPTEM is the issue or APTEM is the issue. FIPTEM, I showed you the last slide, right? Zero activity. Okay. If you can remember that, it's very important. If you don't see any pink line at all in FIPTEM, that means to say it is absent fibrinogen or it's very minimal. Okay. It's not even being detected. Or if it's less than 40 or 4 mm in the A10, it is issue with fibrinogen. Okay. So FIPTEM usually and APTEM, no, start with EXTEM and then go with these two. Okay. If there's abnormality here, then you look at fibrinogen first, then you see whether there is clot breakdown if this is causing hyperfibrinolysis. But if you see that this is normal, okay, but then there is an issue here that this pink line is too big, right? So that time you have to see whether there is an issue with fibrinogen. Okay. Is that clear?
Sir, I wanted to ask, what if the CT is prolonged in extem?
CT is prolonged in extem. Okay. So CT is prolonged in extem, you see intem as well. Both have to be. See, this is not only one thing. Extem, what does it tell you about? It just adds tissue factor to start the clot formation. Rest everything it'll assume to be normal. Okay. It's just going to add your tissue factor. It's not going to tell you much about your clotting parameters. But then you can have some amount of increase in that if you have a lot of factor deficiency. Okay. It can be prolonged, but at that time you have to look at intem also. So that's why you cannot see only extem and then give an answer. Okay, you have to see all the graphs. Basically, if you have to give an answer regarding any rotem, you have to have your extem and your intem. Okay, you cannot isolatedly use extem and tell the answer, or you cannot use isolatedly intem and give the answer. Okay. Any other questions? I hope it's clear. If you are not, you can go back to the videos and pause at each slide and then look at it. Okay. So for giving platelets or FFP, do you need cross matching? Okay. So it's not required. Okay.
Yeah.
So cross matching is not required for FFP, cryo, or platelets in an emergency situation, but the best centers still request you to do the RH factor. Okay. So they tell there might be some reactions to them, and if at all there are reactions, they can attribute it to it. Okay. But in an emergency case, it's not required for FFP, cryo, or platelets, but it's always required for your PRPC. Okay. So remember what each bag of blood contains, how much volume, how much has to be transfused. Okay. These are the questions they can ask you on data interpretation and viscoelastic testing. What is the amount of FFP, like one of you earlier mentioned about your FFP dosing, right? I mean, your cryo dosing. Okay. So all of this has to be known. Okay. So how is platelet stored?
Room temperature.
Room temperature, sir.
So what is the major issue when we have platelets stored at room temperature?
Infection.
Infection.
Risk of infection.
Remember this is one question they'll frequently ask. Okay, so if at all this patient, they'll give you a summary telling that, okay, patient was transfused like this and then patient again had fever. Okay, so if that is there, what would you do is what they'll ask you. Okay, you have to check the bag transfusion. Probably you can take the sample of blood from the patient as well as the sample from the bag. If both match, only then you can attribute the infection to be because of platelets. Okay. So you need to know how much dose of platelets have to be given, what is the dose of FFP, cryoprecipitate. All of this is something that is expected out of you in this station. Okay. So how much does platelets increase by giving random donor platelets? If you give one apheretic unit, how much will it raise? And if you're giving 4 to 6 units of RDPs, how much will it raise? See, this is a very common question, no?
Apheretic can increase up to the 8,000, I think.
Okay, up to 30. And 6, if you give, it can go up to 10,000, 5 to 10,000. Okay. So again, when you're giving cryoprecipitate and FFP, what is the targets you are looking at? What is the amount of, what would you look for?
Fibrinogen levels we have to see.
Excellent. So how
It is
often will
less
you
than 150 and less than 100.
Okay, good. So target is to keep it above 150 grams, milligrams per liter, per deciliter.
Milligram per deciliter.
Okay, so you have to give the proper SI units as well. Okay, they'll be looking for that. Okay, so then there might be questions asking about reversal agents and what is three-factor PCC, four-factor PCC. Okay, and what factors are present usually. Okay, so whenever they talk about three or four factor, the major thing they're looking at are vitamin K dependent coagulation factors like 2, 7, 9, and 10. Okay, so what is not there in three factor? The answer is
Factor
there on this.
7.
Fibrin, factor 7 is not there. Okay, so usually you need to remember all of this. Okay, you need to remember the names of all the factors as well. Okay, so what is the reversal agents if that patient is on dabigatran?
Idarosizumab.
Idarucizumab.
Idarucizumab. Okay, so these are the questions they will ask you. Okay, people are very fond of these questions of lately. So please remember this slide. If you can read it up, it will be good enough. So what is the reversal agent usually for your apixaban, endoxaban, or rivaroxaban?
Andexanate alpha.
Andexanate alpha. Okay, so you remember all of this. Okay, so vitamin K antagonist, whenever there is there, do we have to give vitamin K? Or what do we do?
We can give, but the onset of action will be delayed. So
Correct. Okay.
initially,
Usually, if
let's
the
start with
patients
the four-factor PCC if it is available, or followed by FFP.
FFP. Okay, depends. See, cost. A lot of things will matter at that time. Okay, so the best answer is to tell FFP transfusion, but the best thing is if you get a four-factor FFP. Okay, good. So that's about these things. Any doubts you have in this? I know ROTEM is a little overwhelming, a little confusing, but please compare it. Okay, if you see this slide, I think so you'll be able to correlate your TEG. So whoever knows TEG properly, and you guys, I think so know TEG well. So try and correlate with TEG and ROTEM. Okay. So if you guys have understood it well, good enough. Okay. If not, please let me know. Okay. Should we go to the next one? Are you guys okay with this? Okay. So this is my slide visible?
Yes, sir.
Okay, good. So I just want you guys to be as interactive as you were earlier. Okay, please. This is a practical session and it's not theoretical. So I'll be giving you drugs. So take turns and answer. Don't answer in groups so that others will not hear it. Okay. So if one of you is answering, please wait and then another person can add on. Okay. So let's begin. So whenever I give, sorry.